بسم الله الرحمن الرحيم. يعني احنا النهارده ان شاء الله باذن الله تعالى بنفتتح CardioGo 2020. CardioGo 2020 is one of the activities of the IAVA Society. الحقيقه CardioGo 2020 هيبقى مميز بكلاسترز and bunch of cases and also bunch of elegant panelists, moderators, and speakers. Also, we have 3 symposia, which I think also be beneficial and fruitful for special and elegant presenters and topics. First, I'd like to tell you that we have 4 integrated case scenarios. This is our theme. The first ICS will be moderated by Professor Salim, and we have a bunch of prestigious panelists, Professor Adel Itribi, Professor Ahmed Hassouna, Professor Atif al-Bahri, Professor Karim Saeed, Professor Mohammed al-Nu'mani, and we have 3 interesting cases by Dr. Ahmed Tak, octogenarian with dyspnea, pulmonary embolism with tibial fixation, Ayman Khairi, cabbage is not the end of the road by Dr. Sharif Abdel Samad from Alexandria. ICS2 also will be started 6:30, moderated by Professor Walid Ammar, panelists Professor Gamal Abu Nasr, Khalid Tammam, Mahmoud Fauzi, Sharif Nasr, Yasser Husayn. Very interesting 3 cases. First one by Professor Ahmed Bendari, successful procedure. Do you think again? Meet the challenge, Professor Mitra Dito from UK, and Mission Impossible case by Professor Tariq Rashid. Then tomorrow, Friday, we will start at 3:30 till 5 by another very interesting cases and bunch of panelists and moderator Professor Walid Al-Awadi, panelist Professor Ahmed Hassouna, Professor Ahmed Sabri, Professor Ayman Abu Al-Majd, Professor Hussam Andil, Professor Muhammad Usama, and we will have also 3 interesting cases. Exhaust your investigations by Professor Ahmed Shawi and Shams. Life is full of surprises. You need to know where to look by Professor Muhib Magdi Mansoura. A journey of rendezvous by Professor Ayman Tantawi from Zakazaki. Then we will have at night of Friday another interesting ICS integrated case scenarios moderated by Professor Muhammad Sadqa, panelists Professor Ahmed Hassouna, Professor Diam Shawi, Professor Muhammad Abdel Ghani, Professor Muhammad Sobhi, Professor Tariq Naguib, and the 3 interesting cases: constrictive pericarditis, get out of the sac by Professor Shahab Al-Itribi, a journey of heart failure patient when diagnosis begets more complexities by Professor Karim Mahmoud, and finally an interesting case by Professor Muhammad Zahran, when the buffet is open, which dish you start with. Another interesting case. I think we will have 12 cases. I knew some of those cases. It will be very interesting, very educative, and it also would be interactive. At the start now, we have a very elegant start also by the Vice President of the IAVA, Professor Atif al-Bahri. He will give us the journey of one of the innovation in cardiology and in heart failure treatment, the sacubitril valsartan Entresto, a journey of sacubitril valsartan Entresto in heart failure. We will start the first symposia by our elegant presenter, Professor Atif al-Bahri, after a break. So please wait for 30 seconds and we will start.
Well, I would like to welcome you back again, and let me take this opportunity to be with my colleagues and with you and congratulate dear Professor Said Farag for the opening of CardioGo, annual CardioGo conference. Actually, as you know, CardioGo is one of the activities of IAVA Society, and we are proud of the activity of Dr. Said Farag. I would like in this occasion to thank Novartis company for their continuous support to the CME activity of IAVA Society and all the cardiology field in Egypt. Let me now introduce Professor Atif Al-Bahari. He will present to us the essential intervention, and I'm sure it will be about something important in heart failure. Dr. Atif, tfaddal.
Thank you very much, dear colleague and dear friend, Professor Ashraf Rida and Professor Sayed. Heart failure has been signaled out as an epidemic and is a staggering clinical and public health problem associated with significant mortality and morbidity and healthcare expenditure, and for many years and for 23 million patients worldwide. Therefore, many trials are done to prevent and to manage heart failure. We see here the evolution of heart failure management. The current therapies are aimed at improving clinical symptoms. Several agents more directly target the underlying cause of the disease. Starting by the consensus trial study using enalapril ACE inhibitor in 1987 was the first ACE to be introduced in severe congestive heart failure. In 1996, first beta blocker carvedilol, the USC carvedilol study, heart failure study, the effect of this beta blocker on morbidity and mortality in patients with chronic heart failure. And then the first MRA study using spironolactone was the RAILS study for the morbidity and mortality in patients with severe heart failure, ending in 2001 by the first angiotensin receptor blocker valsartan in a randomized trial for angiotensin receptor blocker, the VALHIFT trial. Despite all these current therapies that improve survival in heart failure patients versus placebo, mortality in heart failure reduced ejection fraction remains very high, as they decrease the mortality, but still about 50% die within 5 years of diagnosis. And 51% experience cardiovascular death at their primary event with no history of heart failure hospitalization. And sudden death can occur without worsening of symptoms by about 40% die of sudden cardiac death. With an exception of lung cancer, mortality in patients with heart failure exceeds that of many cancers. And in developed countries, heart failure is the primary cause of hospitalization in patients aged more than 65 years. And we see here the dilemma of hospitalization, starting from admission, discharge, and readmission, which never end. And we see here 44% of patients will be re-hospitalized at least once. We can see here also, as we see, the heart failure has a detrimental effect on quality of life. And we see 67% of patients struggle to perform with their daily activities, and 63% of patients reported symptoms that are consistent with depression, and 40% of patients struggle to socialize or engage in daily life and routine life activities with friends or families. So after 2001, with the last the VALHIFT trial, it comes here another study, the paradigm study, with angiotensin receptor blocker valsartan with neprilysin inhibitor versus enalapril in heart failure in 2014. And this was the first RNA trial. The evolution of Entresto, the first in-class angiotensin receptor neprilysin inhibitor RNA, as we see, you can see here, this is a novel drug that work in a different ways. It's a novel salt complex, the first in-class angiotensin receptor neprilysin inhibitor. We know that with HFrEF symptoms and progression, there is a stretch of the myocardium leading to sympathetic nervous system activation, as we see with the vasoconstriction, increase the RAS activity, increase the vasopressin, increase heart rate, increase contractility, and activation of the angiotensin II acting on the AT1 receptor by the renin-angiotensin-aldosterone system, leading to increased blood pressure, sympathetic tone, increased aldosterone, increased hypertrophy, and fibrosis of the myocardium. There is a compensatory mechanism occurring on the other side in green. This is a natriuretic peptide system, which with a stretch of the myocardium, leading to the production of natropeptides. These natropeptides are beneficial to counteract the effect of the RAS system by decreasing the blood pressure, decreasing sympathetic tone, increasing natriuresis and diuresis, decreasing vasopressin, decreasing aldosterone, decreasing fibrosis and hypertrophy, and causes and reverse remodeling. But misfortunately, neprilysin here is watching them and destroying them, leading to a production of inactive ingredient. And with the invention of the sacubitril valsartan, we can see sacubitril will inhibit the effect of neprilysin, so it will preserve the beneficial effect of the natriuretic peptide system, and valsartan on the other side will block the angiotensin II, leading to the counteracting the effect of the RAS system, as we see here. And this is very, very elegant. So the paradigm heart failure is a prospective comparison of ARNI with ACE inhibitor to determine impact on global mortality and morbidity in heart failure. So the paradigm heart failure, the number of patients with large, 8,042 patients with chronic heart failure, NIHA class 2 to 4, with left ejection fraction less than 40% and elevated NAT, proPNP or PNP. And there is a marked decrease by 20% of the all-cause morbidity and mortality, reduction of cardiovascular deaths or first heart failure hospitalization. But also there is 20% risk reduction of cardiovascular deaths or first heart failure hospitalization, 20% risk reduction for sudden cardiac death, 16% risk reduction of deaths from any cause, and 23% fewer admissions for heart failure, which is marvelous, and 18% fewer stays in intensive care. So the treatment with Entresto also provides a sustainable improvement of patients' quality of life, and this is very important for patients with heart failure. The treatment of Entresto improves the patient's quality of life, including heart failure symptoms and physical limitations as measured based on the KCC, the county qualification meter. The effect of Entresto on quality of life sustained for up to 36 months over the same treatment period, as we see patients treated with enalapril experience of quality of life decline. So here in patients with HFrEF, Entresto significantly improved nearly all the KCCQ physical and social activities compared with enalapril, with the largest responses in household chores and sexual relationships, which is important for the patients, as we see from this gray and the yellow. In 2016, the American College of Cardiology, American Heart Association, Heart Failure Society of America, and the European Society of Cardiology guidelines ARNI for the treatment of HFrEF. As we see, 2016 recommended sacubitril valsartan Entresto or ACE inhibitor or angiotensin receptor blocker for patients with HFrEF. Recommended sacubitril valsartan in conjunction with evidence-based beta blockers and MRAs in patients with chronic symptomatic HFrEF, NIHA class 2 or 3, who tolerated an ACE inhibitor or ARB. And in the European guidelines, recommendation replacing an ACE inhibitor or angiotensin blocker with sacubitril valsartan in ambulatory patients with HFrEF who are symptomatic despite optimal treatment with an ACE inhibitor, a beta blocker, and an MRA. So can early intervention with Entresto delay or reverse cardiac remodeling, which is a very important question? The Entresto answers all this question by a prospective study of the biomarkers, symptom improvement, and ventricular remodeling during Entresto therapy for heart failure. So in the European Society of Cardiology 2019 updates in the PROOF heart failure study. And this phase for prospective 52 weeks single group open label study for 794 patients with HFrEF enrolled in 78 outpatient sites in the United States. And sacubitril valsartan was initiated and the dose adjusted. The enrollment commenced on October 25, 2016, and follow-up was completed on October 22, 2018. As we see here, the screening period for the class 2 to 4 FREF patients with an open label treatment period, and sacubitril valsartan 50 milligram up titrated to 200 milligram 2 times per day. And we can see here the goals of the study was a primary endpoint, which is very important, the correlation between the change in NT-proNP and remodeling at 12 months, left ventricular ejection fraction, left ventricular and diastolic volume index, left ventricular and systolic volume index, left atrial volume index, ratio of early mitral diastolic filling velocity, early diastolic mitral annular velocity. All these parameters are very important to measure the remodeling, not only the left ventricular ejection fraction. And the secondary endpoints was association between the change in NT-proNP and remodeling at 6 months, the effect of the SCB on cardiac remodeling, the effect of sacubitril valsartan on cardiac remodeling in the specific patient subgroups not represented in the paradigm heart failure trial, the new onset heart failure and or ACE are naive patients, those with PNP or NT-proNP concentrations below the paradigm heart failure inclusion criteria, and patients not reaching target doses of sacubitril valsartan twice daily. The baseline characteristics here for this patient, the subgroups, new onset heart failure and or ACE inhibitor are naive patients, and the number were about 118. The PNP or NT-proNP concentrations below paradigm heart failure inclusion, the number of patients were 292, about 36.8% of patients. And following titrations, there are 35% of patients did not receive the target dose. And here we can see the parameter, the age group, the male sex, NIHA classes, the race, white and black, the body mass index, the past medical history, high hypertension, diabetes mellitus, myocardial infarction, atrial fibrillation and deflator, and the guideline-directed heart failure therapy taking beta blockers, ACE inhibitor, or angiotensin receptor blocker, MRA, CRT, ICD, and ICD alone. Here we can see the reverse cardiac remodeling that happened in the proof heart failure. As we see here, for left ejection fraction, about 25% of subjects experience an LV ejection fraction increase of about 13% at 12 months, as we see from this slide. And the left ventricular end-diastolic volume index was decreased, and the systolic volume index was decreased from baseline to 12 months, and the p-value was highly significant. The reverse modeling number 2 here, we can see the left atrial ventricular volume index here was decreased after 12 months. The EE was decreased also as after 12 months, and the p-value from baseline for 12 months was highly significant. The subgroups of interest here, the reverse cardiac remodeling was comparable. In each subgroup of interest, all have a very high significant p-value expect were noted. As we see from the new onset heart failure, patients who doesn't take ACE or are naive patients, and in patients have NP less than the paradigm inclusion criteria and not reaching the target dose. All these 3 subgroups are very important, and we can see here that reverse cardiac remodeling was highly comparable with and significant on those patients, as we see. So rapid and sustained improvement in the quality of life over the standard score, as we see, starting here from 18, which is highly significant, and this is very important to relieve the symptoms and the hospitalization of the patients and to improve the quality of life within 2 weeks, which no one of the heart failure drugs ever make this, and where it's statistically significant over 12 months follow-up, which, as we see here, is very sustainable and sustained until the 12 months. So, conclusion of the proof heart failure in this study of patients with HFrEF treated with interest to reduction in NT-proNP was significantly associated with reverse cardiac remodeling, which is important. The degree of reverse remodeling demonstrated may help to explain how Entresto reduces morbidity and mortality in patients with HFrEF. The reverse cardiac remodeling was comparable in each subgroup of interest, such as new onset heart failure and or ACE inhibitor or angiotensin receptor blocker naive patients. So another question comes, can we start Entresto in de novo patients? This is very important. The percentage of naive de novo patients in the pioneer heart failure, the transition heart failure, and the proof heart failure, as we can see that de novo is 29% in the transition study. Those patients are naive. And the pioneer, we can see that de novo, 35% are new for the treatment. And the proof heart failure, the de novo is inhibitors, as we see, and they are about the 14.9%. If we look for the transition, initiation of sacubitril valsartan in patients with de novo heart HFrEF, an analysis of the transition study, we can see here the initiation of sacubitril valsartan was well tolerated and safe in de novo heart failure patients. And most relevant, the adverse events at 2 weeks were less in those patients and have the same as the patient taking Entresto, and the proportion of patients achieving the primary and secondary endpoints, as we see. So patients with de novo heart failure are more likely to achieve and maintain target dose of sacubitril valsartan by week 10 compared to those with prior heart failure. So Entresto should be considered as first-line therapy in de novo patients hemodynamically stabilized after an acute decompensated heart failure event, which is very important to start early. In the pioneer heart failure, the angiotensin receptor inhibition in acute decompensated heart failure based on prior exposure to a conventional renin-angiotensin system antagonist is a pre-specified subgroup analysis of the pioneer heart failure trial. As we see here, we can find that this is the ACE inhibitor angiotensin receptor naive patients were 53%, and this gray is they don't take ACE inhibitor angiotensin receptor blocker. And we can see here the change in NAT-proNP concentration, and from here there is no ACE or no ARB group. As we see, the sacubitril was improving here, decreasing the NAT-proNP, as we see. And yes, taking ACE or ARB, we have decreasing of the NAT-proNP concentrations, and the p-value in both here are very significant. The Kaplan-Meier estimated cumulative incidence of cardiovascular death or rehospitalization for heart failure was decreased in the arm of sacubitril in patients with no ACE inhibitor or ARB group, and in patients also, yes, taking ACE or ARB and then shifted to sacubitril. But we see here early as the 7 days, we find here the gap that opened between the two curves, which is very marvelous, and we should interfere and intervene very early. The conclusion here of the pioneer heart failure, patients admitted with a primary diagnosis of acute decompensated heart failure, irrespective of prior ACE inhibitor or angiotensin receptor blocker exposure, Entresto was safe and well tolerated when compared to a conventional RAS antagonist. In hospital initiation of ARNI resulted in a greater reduction in NAT-proNP levels, a reduction of rehospitalization for heart failure, which is our mainstone. The Entresto titrated to target dose based on systolic blood pressure should be considered, and the line therapy for patients with acute HFrEF independent of previous RAS exposure. In May 2019, there is a clinical practice update on heart failure, the pharmacotherapy procedures, devices, and patients management, an expert consensus meeting report of the Heart Failure Association of the European Society of Cardiology. And we can see here the consensus recommendation regarding Entresto. First, initiation of Entresto rather than an ACE inhibitor or an angiotensin receptor blocker may be considered for patients hospitalized with new onset heart failure or decompensated congestive heart failure to reduce the short-term risk of adverse events and to simplify the management by avoiding the need to titrate ACE inhibitor first and then switch to Entresto. We should take this in our concentration, and they said they may be considered. So because these patients are already at high risk of events, there is no need to check, as we see, to check the plasma concentrations of nephritic peptides prior to initiating Entresto. And in the ambulatory setting, the guidance remains mostly unchanged. However, the paper states Entresto is safe and effective in a broad spectrum of patients with HFrEF. Its safety is similar in ACE inhibitor and angiotensin receptor blocker naive patients, and thus its initiation may be considered also on these patients. So a comprehensive clinical program supported by Novartis to further investigate the heart failure space, as we see, starting from the paradigm heart failure, and then the titration study, the transition study, the pioneer study, the proof heart failure, which I told you, the evaluate heart failure, the Paragon and the Paradise. As we see, this is completed and this is ongoing. And Entresto is an essential heart failure intervention, very important, and we see it in our patients during the practice, and it improves the quality of life of the patient, reduces hospitalization, and make a change in the heart failure management. My conclusion is new therapies for heart failure are needed that can more fully address factors responsible for the underlying progressive cardiac dysfunction, simultaneous inhibition of neprilysin and suppression of the RAS system with circuitry valsartan has complementary effects. Entresto significantly reduced death from cardiovascular causes or first hospitalization for heart failure or cause mortality, improves the patient's quality of life, which is very important. The proof heart failure cause reduction in NT-proNP with Entresto was significantly associated with reverse cardiac remodeling, which is offensive to the myocardium. The new Heart Failure Association consensus conveys a positive message for all of us, for all the practitioners treating this epidemic, for Entresto on heart failure with a reduction of the reduced ejection fraction, HFrEF, with a first-line recommendation being listed for the first time. And I say we should not wait for the patients to try ACE and to try angiotensin receptor blocker, and then we shift to the Entresto. I can see here from all this data that we should start early, and intervention early is very important to have a good quality of life and to prevent the hospitalization and to reverse the cardiac remodeling, which is offensive for the myocardium. And thank you very much for your attention, and thank you.
Thank you, Professor Atif. Actually, while I'm listening to your presentations, I recall now a relatively long history of using Entresto with accumulation of the data in many clinical scenarios. Even in the initial paradigm heart failure trial, the inclusion criteria include patients with just class 2 heart failure. So, first message, I think we should have the courage to give these combinations and not waiting till the patient becomes severely symptomatic. Because one of the inclusion was patient with mild symptoms.
Yes.
So if the patient has reduced ejection fraction and mild symptoms, we can use this combination. The second message from your presentation is that even in those who do not using ACE or ARBs, we can start with Entresto. We can start with this combination. We now have the evidence that it is safe. It is effective in reducing PNP. It is effective in remodeling, and it may be effective in long-term even prognosis. So I think the last two slides with the consensus, new consensus of European consensus, we have to say that it may be considered in those who are even naive for ACE or ARBs. And
I want to add
elaboration to these points.
Thank you. I want to add one point before I go. When you prescribe and try with heart failure patients, starting with ACE inhibitor and or angiotensin receptor blockers, and the patient is not improving, taking a polypharmacy, diuretics, MRA, beta blockers, ACE inhibitor, and he's still suffering. With adding Entresto to our patients in the last few years, we deduct the polypharmacy. There is no diuretics in the prescription. There is no MRA description, and even beta blockers. So you consume many drugs away from this patient, and the patient feels healthy and no hospitalization, and have a good quality of life. If I start with ACE or ARB and the patient is not well, and after I replace it by Entresto, and he improved, he will ask me one question: why you don't start from the beginning this drug with me? So we have to intervene early, as Professor Ashraf said, and as I said, and I think most of us working for heart failure patients see the importance and the marvelous effect of this sacubitril valsartan, and more and more data now are coming, and we see the remodeling, which is improving in 14 days after 2 weeks, which is marvelous, because there is in the vascular biology, when you study the effect of nitropeptide on the myocardium and the effect of angiotensin 2 on the myocardium, and you see the bi-force. It's a bi-force of valsartan acting to prevent the remodeling by preventing the fibrosis and preventing the effect, the deleterious effect of angiotensin 2 in the myocardium. Also, the natriuretic peptide has a very important effect on the cyclic GMP acting on the myocardium, on the sarcomeres itself. If you go deep dive inside the myocardium, in the sarcomeres, you will find this effect of the natriuretic peptide that is given by our God to help the myocardium, and now you help it by the sacubitril inhibition of neprilysin.
Okay. Before Dr. Syed conclude and comment, last point I want to elaborate another clinical scenario: those patients admitted with acute heart failure. Because this is another important situation in which, with certain conditions, of course, you have to stabilize the patient first. You have to wait for 1 or 2 days without increasing the dose of diuretics, without hypotension. But it is better to start before hospital discharge, giving the patient Entresto. This will cut the long story short and starting the early benefit from immediate post-discharge time. Dr. Syed,
100% correct, Dr. Ashraf.
I think there is no more comments or question. I just like to highlight that it is a time to use this innovation in a treatment of heart failure. It is a time to use the evidence behind this innovation in treatment of heart failure, either in patient with chronic heart failure or even in the transition for patient admitted in the ICU. I think because of the evidence, also because now we have the health insurance supporting this drug, we have the patient support supporting this drug. I think it is the time to use this evidence innovation in the treatment of heart failure. And I'd like here to conclude this symposium, and I'd like you all to go for CardioGo 2020. We will start after a few minutes the first integrated clinical scenario. Thank you, our elegant Professor Atif Bahri, for this elegant and comprehensive presentation. Thank you, Professor Atif, for this kind and very elegant moderation for this session. Thank you very much.
Thank you very much. Thank you.
Hello, everybody, and welcome you again. This is the opening of the CardioGo annual virtual congress. I would like to welcome you all. And today with us we have a group of stars. First of all, I would like to thank Professor Said Farag for his enthusiasm and for his effort to bring CardioGo, which is one of the important activities of YAVA Society, of the CME activities. As you know, our society has many activities. We have cardio risk waves. We did now about 9 or 10 waves since the Corona period. We have the standalone webinars. We have the Cardio Go, of course. We have the BCC next month. We have the cardio risk in Hurghada. We have a lot of activities, and I hope all of you are enjoying these activities. Again, I would like to thank Professor Said Farag, and I will let him to lead this interesting Congress. And I hope for you, Sayed, and for all our boards and for our guests, all of the best and enjoying your time. Dr. Said, Fadl.
My dear professors, my dear colleagues, dear attendees, it is a great pleasure, a great honor to be starting now and launching now the Cardio Go 2020. Really, it was a dream, and it comes true with this bunch of stars, with this bunch of scientists, with this bunch of cases. I know 12 cases, well prepared, very educative, very interesting. You will see cases, I think, for the first time. This is our theme of the Cardio Go, just cases. This is the module, one of the CME modules of the Egyptian Association of Vascular Biology and Atherosclerosis. And I hope that it will be fruitful, will be beneficial. And also I'd like to thank all my dear professors who accepted the invitations. Really, they will enrich by their knowledge this event. And I'd like to thank the sponsoring companies for their support, Novartis, Sanofi, Medtronic, Eva Farm, and also Merck Serono for their support. I'd like also to thank ICOM for their fantastic organization, and we will see their effort all through the Congress. Now I will leave the mic for the first ICS, first integrated case scenarios, and it will be led and moderated by Professor Mohammed Salim. I hope that you will enjoy the sessions and we will follow these interesting cases. Thank you.
I think we can take 30 seconds off and then come back to with Professor Salim.
Good evening, everybody. It's my pleasure to be part of this very honorable panelists and speakers with Professor Said Farag, with Professor Ashraf Rida, the president of YAVA and the president of Cardio Go. And I will share this session with eminent professors, Professor Adil Itrebi, Professor Atif al-Bahari, Professor Karim Saeed, Professor Naumani, Professor Ahmed Hassouna, and also we have 3 very interesting and complex cases. I think every one of them has many messages in both the practice and the knowledge. It's my pleasure to introduce the first speaker, Professor Ahmed Tag from Suez Canal University. He will present his first case about octogenarian with progressive dyspnea, and his case will be moderated and discussed by Professor Ahmed Hassouna and Professor Mohammed Mohamed. Dr. Ahmed.
Thank you. Bismillah ar-Rahman ar-Rahim. I'd like first to thank Professor Salim for sharing this session with all other colleagues. And I'd like to present my warm thanks to Professor Said Farag for inviting me for this IAVA activity, which I think one of the best scientific activities, I think, for this year. So my case is octogenarian with progressive dyspnea. I hope to invite you all to Ismailia very soon in one of IAVA activity on behalf of Dr. Said Farag, of course. And we will have some other activities for ISMA as well, Ismailia Cardiometabolic Association. Very soon, we'll be very happy to invite you there. So again, thanks for CardioGo. And this is the slogan which I like to present. Treat often, cure sometimes, comfort always, and harm nothing. This is Mrs. MK, is an 80-year-old lady presented to outpatient clinic complaining of progressive shortness of breath over the last 3 to 4 weeks. She has insulin-dependent diabetes mellitus for 35 years, hypertensive for 38 years on medical treatment, no history of chest pain, syncope, palpitation, or recent hospitalization. Clinically, she looks ill but conscious and oriented. Oxygen saturation 87%. Heart rate 105 beat per minute, sinus rhythm was infrequent BVCs, blood pressure 110/70, temperature 37.4 Celsius degree, respiratory rate 22 per minute, mild bilateral lower limb edema, lax calves, faint distal pulsations, galloping heart with systolic murmur over left parasternal border, apex is outside mid-clavicular line without thrill, chest fine basal crackles, abdomen lax, and no definite organomegaly. So work up, as you see here, sodium and potassium normal. Maybe potassium is in the upper part. Random blood sugar is very high, as well as hemoglobin A1C, mild anemia, 3.7 milligram per deciliter serum creatinine, impairment of kidney function. Left liver function test slightly elevated, ALT, AST, INR is 1.6, LDL is 235 milligram per deciliter. This is her current medications, captopril, hydrochlorothiazide combination, atenolol, gliclazide, aldactone, and ascosid. So this is her current medication. So MCQ 1, systolic murmur over left parasternal border in an 80-year-old lady with diabetes and hypertension, complaining of progressive shortness of breath. What's the least common differential diagnosis? Mitral regurg, VSD, aortic stenosis, or tricuspid regurg. For me, I will go for VACD, of course. So this is her ECG, cues from V1 to V6 with a slight elevation from V1 to V4. Significant STT changes in the anterior and the inferior leads as well. This is her parasternal long axis view, a kinetic anterior septum, as you could see here, dilated LV. And this is another view where this is apical four-chamber view with a kinetic, dyskinetic apex and apical septal part, dilated LV. I hope you can hear me. ICOM team, can you hear me? Okay, thank you. So dilated LV, a kinetic, dyskinetic apical septum, and there is, as you could see, you could appreciate, there is a significantly large apical thrombus, as you see here. So we have a kinetic LV territory, LV apical aneurysm, large LV apical thrombus, poor LV function. We have to search for
احمد بعد اذنك لو في فيديو يعني مش سني يا ريت لو افيلابل يعني.
This is video here.
Yeah.
Can you see this?
Yes. Okay.
Okay, so I'll repeat again بس ده مش هيتخصم من الوقت بتاعي بقى. ده الباراسترنال لونج اكسس يا فندم اكاينيتيك ليبيتوريتري وده الابيكال فور تشامبر فيو اكاينيتيك وفي ديسكاينيتيك بارت اوف ذا ايبكس وفي اللي في apical thrombus I think is appreciated here. Can you see it? وطبعا for mitral regurg because of what I listened to and frequent BVCs during echo. However, there is no significant mitral regurg. So, and no aortic stenosis and no tricuspid regurg. So this is apical septal screening by double. What do you think? So there is color lesion over the apical septal part here, consistent with apical septal ventricular septal rupture, and it's less than 1 centimeter, as you could see here, about 0.85 centimeter. And the gradient was about 30 millimeter mercury with the velocity 2.1 meter per second. So this is the echo resume. Poor LV function, ejection fraction 30%, akinetic, dyskinetic LED territory, no MR, no pulmonary hypertension, LV thrombus, LV aneurysm. So this is MCQ2. Which of the following is not a risk factor for ventricular septal rupture? STEMI, higher heart rate, high blood pressure, higher Kellett class, delayed or lack of reperfusion? And the answer is high blood pressure, because usually low blood pressure is associated with ventricular septal rupture. MCQ3, what's the next step to do? Hospitalize, optimize, and no intervention. Hospitalize, optimize, then reevaluate. Hospitalize, coronary angio, then surgery versus percutaneous closure. Or with this step number 3, you will put intra-aortic balloon counterpulsation. And the appropriate answer, which Webby has done, is hospitalize, optimize, then re-evaluate. So the patient admitted after orientation of the patient and family, decision was to hospitalize and optimize the kidney status, heart failure, diabetes. Nephrologist, diabetologist, and actually gastroenterologist were consulted, admitted to CCU, and stabilized in less than 3 days. After assessment, she looks fair, conscious, oriented, heart rate dropped to 78 beats per minute, blood pressure 120/75, no further edema, no further cracks. Still there is systolic murmur, of course, which is the VSR. Follow-up of the lab, creatinine dropped to 3.1, however, still high. Blood sugar improved, 175 milligram per deciliter. Potassium improved a little bit. However, ALT/ST2X elevated with INR physiologically 1.9. Abdominal ultrasound revealed grade 2 to 3 echogenic cadence, which is going with the diabetic state of this patient and hepatomegaly. What happened next is MDT meeting to what to do further for this patient. Nephrologist refused any intervention. Diabetologist and gastroenterologist agreed with very high risky consent. Cardiac surgeons and anesthetists admitted patient is not a reasonable surgical candidate. Cardiologist team, as you see here, family refused any interventions, even diagnostic coronary angiography. So medications now are valsartan 80 milligram, torsemide 10 milligram, metoprolol 100 milligram, insulin, atorvastatin, aspirin, and clopidogrel. This is echo at discharge. LV thrombus maybe a little bit lower, function maybe improved a little bit. I can't tell 100%. Of course, the VSR is still as it is. So what's the next plan? Conservative management, conservative and reinforce the need for surgery, or conservative management and another MDT. So our decision was to do another MDT after conservative treatment. At 6 months follow-up, patients looks for stable on medications and with almost same echo data. NIHA function class 2, lab somehow improvement of kidney function, however, still 2.7 milligram per deciliter. Patient and family discussion for another MDT meeting, but they refused to do any interventions. So are you satisfied? Who is at risk for VSR? Old age, female gender, prior stroke, STEMI, higher heart rate, lower blood pressure, higher Kellogg class, and delayed or lack of reperfusion. So another MCQ, according to Picker and Van Mantagam classification of VSR, this lady has type 1 VSR, type 2 VSR, or type 3 VSR. Actually, it's type 3, which is apical VSR associated with proximal LAD total occlusion. So VSR is not uncommon. In era of reperfusion therapy, it was somewhere between 1% and 3%, but after this era of primary PI, it's less than 0.5%. And this is Picker and Van Mantagam classification. VSR type 1, slit-like tears with inferior MI. Type 2 usually is subacute with infarct erosion associated with neutrophilic infiltrates. And type 3, which is, as this lady, apical septal perforation of thin myocardium in late phase of MI without reperfusion. So this is MCQ number 6. Literature suggests a graded decline in mortality with urgent VSR repair, delayed VSR repair, transcutaneous septal closure, or in-hospital VSR repair. And the astonishing answer is that literature suggests a graded decline in mortality with delayed VSR repair. So management of VSR in literature is surgical. This is the definite management. However, surgical outcomes is very poor. This is analysis of about less than 3,000 patients with VSR, high mortality rate about 40% within 30 days, and with delayed procedure, it might drop to 20%. In shock trial, surgical VSR mortality was about 80%, which is very disappointing, as well as transseptal closure. Optimal timing, according to ECC, American Heart Association, emergent surgical repair is preferred. According to European Society of Cardiology, delayed repair in hemodynamically stable patients. Delayed surgery in hemodynamically stable patients may be considered when surgical anatomy is complex. In stable but inoperable patients, transcutaneous closure for small defects is warranted. And this is the consensus management of VSR. If patient is in cardiogenic shock, cardiac support is important, like ECMO or any mechanical circulatory support as bridging or palliative care. If patient is stable hemodynamically, but non-surgical, so transcutaneous or conservative, like Our Lady. If she has a stable or he or she has a stable hemodynamics, early surgical or delayed surgical according to the general status. Non-surgical managements include ECMO or intra-aortic balloon pump counter pulsation if patient is collapsed, intravenous diuretics like our patient in pulmonary congestion, vasopressors in circulatory collapse. And this is actually my last slide, where you can clearly see that with delaying of VSR closure, mortality drops to 10% compared to 60% with early VSR closure. And this actually, as I asked it in one of my MCQs, is noted in literature due to increased stability of peri-infarct myocardium, rendering repair more successful, as well as survivorship bias. So this is my take-home message, Mr. Chairman, Professor Salim, and or other colleagues. Post-MI VSR is rare, but is still there. So you should think about it. VSR should be ruled out in acute MI setting without primary PCI or delayed or no perfusion. MDT consultation is mandatory for all patients with comorbidities, as well as patient discussion and family discussion. That's very important. Conservative management is sometimes the best option for some patients. And finally, clinical skills are still your essential tool of precise patient evaluation and management. Thank you. Dr. Salim?
Dr. Ahmed, thank you for your very interesting case that went through abnormal, although very happy scenario. This is not a routine for a case of VSR, but I think you did a great job by proper consultation with all the physicians and doctors involved, a multidisciplinary team, as you mentioned. And I'm happy to have a great professor, Professor Ahmed Hassouna, Professor of Cardiothoracic Surgery from Shams University. And we want, as cardiologists, almost in our meetings, we are eager to hear the opinion of surgeon in such case. Professor Ahmed Hassouna.
مساء الخير جميعا ليكم جميعا. وطبعا انا يعني في رايي هو كان اكسلنت مانجمنت صراحه، يعني ما كانش ممكن واحد يعمل احسن من كده. الحاله دي طبعا فيري ريسكي، ومعظم الجراحين خبرتهم فيهم قليله. يعني احنا يعني عن نفسي انا بقالي 30 سنه اشتغلت يمكن 4 حالات، خبرتنا فيها قليله سبوراديك، فمحدش عنده جمع خبره كويسه بحيث ان هو يقدر ان هو يدي فيها راي عملي. الاراء موجوده في الكتب او كلنا بنقراها ومفيش مشكله فيها، بس العملي يعني الخبره العمليه عندنا، طبعا بتكلم عن نفسي وعن القسم عندنا، قليله فيها. انا شايف ان المانجمنت ده اكسلنت، والراجل مشي بكل ستيبس الساينتفك اللي المفروض نمشي بيها، و كونجراتيوليت هيم، وماليش تعليق اكتر من كده في هذا الموضوع.
اوكي. احنا دايما بنسمع دكتور احمد ان لما نيجي نعرض حاله زي كده على الاخوه الجراحين يقولوا لنا ستابلايز فيرست. لما نيجي نعمل الريبير التيشوز بتبقى فرايبل والنتائج ما بتبقاش كويسه، ولو ان لو الفي اس ار لو ما اتعملتش فيري ايرلي المورتاليتي بتبقى فيري هاي. فان يور اوبينيون واتس يعني طبعا this case كان ليها special considerations, but if we will intervene surgically, what's the optimal time for doing surgical repair of such cases?
طبعا انا متفق مع الراي اللي سيادتك بتقوله. انا هتكلم عن يعني يمكن اذكر حاله من ضمن الحالات اللي عملتها. يعني احنا راجل اللي اشتغلناه كان، بس هو كان سنه صغير، كان حاجه و40 سنه. عايز افتكر بس مين كان معايا من عين شمس. عايز افتكر بس حد من الاساتذه، بس معلش بقى يعني واحد عجز ماشي يفتكر، حتى هو دخل وصور العمليه وكده. احنا فتحنا الراجل 6 مرات، يعني فتحنا الراجل ري اوبريت عليه 6 مرات for extensive bleeding due to fragility of tissues. يعني فاكر وهو مشي كويس، يعني كويس دي بين قوسين، يعني قصدي سرفايف. انك انت في الاخر انت كنت بتعمل باكينج بكل التيشوز اللي حواليك عشان بس تقدر تخرج من العيان. يعني fragility is a serious problem. بتقابلنا طبعا في الاكيوت ديسكشن، وبتقابلنا في الرابشر. It's a very serious problem. يعني tissues must hold. وعشان كده انا شايف ان الديلي، يعني واضح ان الديلي انترفنشن لما العيان يبقى ستيبل دي من ناحيه، على سيموديناميكال ستيبل من ناحيه الكلى والى اخره، وفي نفس الوقت التيشوز تبقى فيها يعني تبقى فيرم شويه بحيث انها it can hold stitches. Sometimes it cannot hold stitches. فانا شايف ان هو المانجمنت ممتاز، وديلي مانجمنت ستابلايز بيرز اند مانجمنت. في بعض الناس عندهم خبره ان هم بيتصرفوا في حالات فيري ايرلي، بس انا عن نفسي وما اعرفش حد من الاصدقاء الاعزاء، يعني اكيد في مصر طبعا ناس مهمين، بس عنده خبره في ان هو يقدر يتصرف مع حاله tissues are so fragile that it cannot hold stitches. فانا شايف ان stabilization وتدي فرصه للتيشوز انها تبقى مور تف، هو ده احسن مانجمنت للعيان يعني.
تمام. دكتور نعماني، راي حضرتك؟
دكتور احمد تاج، طبعا انا بشكر حضرتك جدا الاول على الفيري نايس اند تاف كيس. الحقيقه فيري ديفيكالت اند تاف سيناريو، الحقيقه يعني حاله بمواصفات صعبه جدا. انا طبعا زي ما الدكتور احمد حسون قال اجرينج بحكم حاجات كتير جدا، واهمها الاوكتوجينيريان نيتشر اوف ذيس بيشنت، طبعا لانه ده هيفرض علينا سيتويشن معين بشروط معينه، خصوصا احنا بالنسبه لنا للريلاتيفز واهل البيشنت في الايجيبشن ثينكينج بتاعنا في الوضع اللي زي ده. بس انا ليا 2 كومنتس. ليه بعد الاستابيلايزيشن ما اعملش تاني ري ايفالويشن واعمل فايابيليتي ستادي؟ وفي نفس الوقت انا محتاج اعمل يعني اشوف السيجنيفيكانس اوف ذس شنت، على الاقل حتى لو انا مش هتدخل سيرجيكال يبقى في a future plan to يعني do an intervention through cardiac cast. بس انا مش هبدا السيناريو ده تماما الا اذا كان في some sort of viability. فانا I think بعد الاستابيلايزيشن وبعد تعديل الادويه زي ما انت تفضلت واشرت يعني كان المفروض ان انا ابص على الميوكارديال فايابيليتي. I think so. يعني ده كان هيبقى بالنسبه لي، هل هتنيني على نفس السيناريو فور ايفر ولا ممكن اغير المايند سيت بتاعي ليتر اون، خصوصا لو انا فهمت الريلاتيفز ان لها تشانس.
اولا ثانك يو فيري ماتش بروفيسور نعماني وبروفيسور احمد حسونه فور يور انبوت. وبالنسبه لسؤال حضرتك يا فندم، طبعا this is very valid question. الموضوع ده كان يقابله حاجتين، احنا هنعمل حاجه للعيانه ولا لا؟ ده السؤال الاول. السؤال
انا بعد اذنك هقطع كلامك، هاخدها بالعكس. لو هي طلعت فايبل انا هيبقى عندي سام سورت اوف موتيفيشن، مش فايبل انا مش هبتدي الستوري من الاصل وهمشي زي ما حضرتك مشيت. ده كان قصدي ان انا هاخدها بالعكس.
تمام. هي يا فندم مبدئيا اكاينيتك ال اي دي وثيند اوت، ويعني في اوريدي انيوريزم، وبالتالي الفايبيليتي في الجزء ده اوريدي از نوت ذير. انا مش معترض، بس انا بقول لحضرتك جنرال سبيكينج الايجكشن فراكشن 30%، وده سبب ان الشنط قليل. احد الحاجات اللي تخلي الشنط قليل زي ما حضرتك يمكن شفت كان حوالي 2 متر بير سكند، يعني حوالي 30 35 ما كانش يعتبر جريت شنط. ليه؟ هي ما عندهاش بالمونري هايبرتنشن، واحد عندها فيري بور ال في سيستوليك فانكشن، فده اللي مش مخلي الشنط فيري هاي، وغالبا ده اللي مش مخلي يعني ان عيانه ان جريت شوك. هي كانت اوريدي هايبرتنسيف وابتدى الضغط ينزل، وده يمكن ساعد على ان الشنط ما يبقاش فيري هاي. الفاميلي اولا دي فيري ريال كيس، والعيانه لسه لحد دلوقتي الحمد لله الايف، وانا قلت بالظبط اللي حصل. والله انا لم ازيد شيء ولم انقذ شيء، حتى الحاجات الديفكتس هي كده فيها. انا قلت لهم
ريال كيس، اتس ريال كيس.
ريال كيس، يعني عيانه حقيقيه وممكن تشوفوا حتى دي، والحمد لله هي لسه عايشه باي ذا واي يعني. فانا قلت لهم يا جماعه احنا لازم هنعمل ري ايفالويشن وان دي تي تاني، لان الكرياتين ابتدى يتحسن والضغط ابتدى يتحسن، نشوف ممكن نعمل ايه. هم they were refusing تماما. هم كانوا هابي جدا بالميديكال تريتمنت، وان السكر اتظبط، وان الضغط ما تاخدش علاجات ضغط كتيره، والعيانه ماشيه كويس. فهم really they refuse everything. ويمكن لو تلاحظ حضرتك انا من ضمن الام سي كيوز اللي حطيتها ان احنا عايزين نعمل تاني ان دي تي ميتنج، ممكن اعرضها لحضرتك تاني باي ذا ريفيوزد، وده كان هيبقى انكلودد ان انا اعمل ري ايفالويشن للشنط مره ثانيه. لكن خد بالك طبعا حضرتك ان ذات نفسه هو كان حوالي 0.85، يعني اقل من 1 سنتيمتر يعني. حتى هو كمان فاليد حتى للترانسبتال كلوجر which is less invasive، لكن هم كانوا رافضين حتى الكورونري انجيو الدايجنوستيك اللي قلت لهم ده مفيش مشكله فيها يا جماعه. بس هو قال لك لا الكدني، والنفرولوجيست كان insisting ان ما نعملش اي حاجه للعيان. قال لي you will kill the patient by getting her into acute renal shutdown, she will not survive. وهو فعلا قال لهم كده clearly يعني. فطبعا يعني your point is valid، لكن ده really هو ده اللي حصل.
Thank you, Dr. Ahmed. Professor Adil Etrebi, what's your comment about this case, especially in the last few months we faced by the COVID crisis and so many patients with late thrombolysis, PCI, primary PCI was less than before and expected to be VSR and mechanical complications more and more. What do you think about this case and what's the best management in your opinion?
طبعا اولا طبعا بادئ في بدء I would like to thank Dr. Said Farag for inviting me, و thank محمد سليم for moderating this very important session. الحقيقه الكيس دي very interesting، وانا بس ليا كومنت ان you don't need viability for shunts. انت عايز evaluate الشنط whether it's a big shunt or a small shunt, because viability will not differ your decision to close the shunt or not. What will you make the decision to close is the pulmonary pressure, the shunt degree, the size of the VSD, and the general condition of the patient. So I think if it's smaller than 1 centimeter and the pulmonary artery pressure is less than half systemic, then I would rather think of conservative management. If the shunt is more than 1 centimeter and in a suitable place for interventional closure, and the pulmonary pressure is more than half systemic, I would think of closing this effect by, and we have series in NCHAMS with Dr. May. She did several cases, May Hamd Said, of transseptal closure of the VSD. And I think this is a very good case, and I thank Dr. Ahmed Tek for giving us the opportunity to know the instance, and the delayed closure is better than immediate, which I think is the usual strategy even for myocardial infarctions for the surgeons. والدكتور حسون قال الكلام ده يعني، وبحييه طبعا على وجوده معانا، والدكتور نعماني برضه بحييه. واي ثينك ان وجود ثرومبوليتيك ثيرابي بيغير المفاهيم. احنا عملنا سيرفي مصري كنا لسه عارضينه الاسبوع اللي فات، باين ان في increased use of thrombolytic therapy ما كانش بيستخدم، و decreased incidence of myocardial infarction في البيريود بتاعت الكوفيد، وده لاسباب كتيره بقى اللي بنقولها في ميتنج تاني.
شكرا جزيلا دكتور عادل بيه. ثانك يو
دكتور احمد، حاله عظيمه جدا. دكتور سيد, this is the first case, and will you please introduce the next speaker, Professor Ayman Khairi. He will give us a very interesting case, very complex scenario. تفضل دكتور سيد.
We come now to one of interesting cases of this session, which will be presented by my dear brother, Professor Ayman Khairi, Professor of Cardiovascular Medicine at Asyut University. He is one of the eminent cardiologists and interventional cardiologists also. He will give us an interesting case of acute pulmonary embolism dilemma in diagnosis and treatment. I think we will face an interesting case with a lot of tips and tricks in the clinical scenario and also in the management. Let us see this interesting case. Please, Dr. Ayman.
بسم الله الرحمن الرحيم. أنا بشكر دكتور سيد بيه والإيافا جروب على الفيري انترستنج ميتنج. بشرفني وجودي مع الدكتور عادل والدكتور سليم والدكتور كريم والدكتور عاطف والدكتور أحمد، وإن شاء الله يعني نستفيد. دكتور أحمد بيه حسونة طبعا نتناقش سوا في الحالة دي. هي male patient 50 years old, no risk factors, smoker, not hypertensive, not diabetic. حصل له موتور كار اكسيدنت من 20 يوم، ورايت تيبيال فراكشر، ونجلكتد فور 2 weeks. كان في أسوان وكان بيد ريدن الفترة دي before seeking medical advice. لما عمل Orthopedic Consultation the decision was to perform tibial nail fixation surgery. بعد successful surgery the patient suddenly arrested during transportation to the ward. تعمل CPR والcardiac rhythm returned but ما فيش documentation within few minutes. في الأورثوبيديك وورد البيشنت drowsy tachycardic 150 beat per minute, blood pressure 80/40, hypotensive and hypoxic, oxygen saturation 84 على room air 84. وفي respiratory distress والcardiac examination والأوسكالتيشن ما كانش فيه حاجة يعني ما كانش فيه significant problem و no neurological deficit. في الوضع ده differential diagnosis غالبا هيبقى كل الحاجات دي hypovolemic لازم تشك فيها, pulmonary embolism, acute coronary syndrome, arrhythmia. لكن pulmonary embolism must be kept in mind for all checked patient after surgery. وده ال ECC 2020 guidelines على risk factors بتاعت ال VTE, وقالوا إن الفراكشر lower limbs هو strong risk factor. once happened acute pulmonary embolism بيحصل spiral of problems آخرها obstructive shock والdeath. لازم نقطع البروبلم دي. our patient had a hemodynamic instability based على الديفينيشن ده هو cardiac arrest ويحتاج CPR. والديفينيشن بتاع hemodynamic instability include obstructive shock أو persistent hypotension. وتبع revised Geneva classification العيان ده يعتبر suspected pulmonary embolism لأنه واخد أكتر من 3 نقط أو pulmonary embolism likely. طب هنعمل إيه للعيان ده؟ لازم نعمل initial stabilization للعيان. أول ما suspect pulmonary embolism أول حاجة بندي intravenous heparin 80 international unit per kg. 80 international unit per kg once you suspect pulmonary embolism. Rapid ECG to exclude acute coronary syndrome, echo bedside لو موجود to exclude other cardiac causes, confirm right ventricular dysfunction, تحطه على أكسجين، تديله saline من 200 ل 500 مللي عشان right ventricular dysfunction، وتديله positive inotropes دوبيتامين مع النورابinephrine vasopressors. يبقى أول خطوة initial stabilization زي ما هو واضح. initial stabilization حتى الintubation. once initially stabilized confirm the diagnosis ب-CT pulmonary angio. once you diagnosed go to reperfusion اللي هو هيبقى thrombolytic لو مفيش contraindication. لو في contraindication يبقى surgery أو catheter embolectomy. دي سلايدز بتلخص المانجمنت بلان. ودي الفوليوم اوبتمايزيشن من 200 ل 500 مللي في 15 ل 30 دقيقة. والنورابinephrine مع الدوبيتامين بيحسنوا رايت فنتريكولار ديسفانكشن وبيزودوا السيستميك بلاد بريشر ويقلل الافتر. بعد لما عملنا انيشال ستابلايزيشن للعيان اتنقل للانتنسيف كير يونت وحصل كاردياك كونسلتيشن. عيان دلوقتي احسن. البلاد بريشر 90/60 اون بوزيتيف انوتروبس. ستيل هايبوكسيك وستيل ريسبيراتوري ديستريس. ECG في تاكيكاردي مفيش اكيوت كوروناري سندروم ولا في اريزم مفيش سبيسيفيك تشينجز. والارتيريال بلاد جازز على الاكسجين 20/60 كان ستيل هايبوكسيك. تروبونين كان بوزيتيف والهيموجلوبين وزين نورمال 13 والكرياتينين نورمال. العيان ده suspected high risk pulmonary embolism لسه مش مشخص. طب نعمله دي دايمر ولا لا؟ الإجابة لا. العيان الدي دايمر مالوش أي لازمة في العيان البلمونري امبوليزم suspected. وبعد عملنا initial stabilization بتبقى الخطوة الثانية confirm الدايجنوزس. فكان سؤالي هنا ايه البيست ايمجنج موداليتي؟ تبدأ بالإيكو ولا السي تي pulmonary angio ولا العيان شوك دي يبقى على طول تتعامل معاه لأنه pulmonary embolism تدي anticoagulation ولا according to availability and clinical circumstances. العيان ده كان السي تي pulmonary angio أسهل فتعمل له سي تي pulmonary angio على طول وانا هوري لحضراتكم السي تي بتاعه. ودي الجايد لاينز بتاع الاي سي سي 2020. البيست سيناريو هو ان انت تعمل ايكو لو موجود الرايت ventricular dysfunction يس يبقى السي تي pulmonary angio بعديه تو كونفيرم الدايجنوز. لكن في الحاله بتاعتنا كان الايكو بعيد عن العيان والسي تي اقرب، فزي برضو ما الجايد لاينز قايله يا ده يا ده، فده عملنا سي تي في العيان. وزي ما حضراتكم شايفين في saddle shaped thrombus obliterating الرايت والليفت هي main pulmonary arteries. خلاص كده انا كونفيرم الدايجنوزس، بعتوا جابوا الايكو بعد لما عملوا السي تي، وكان في كل الساينز بتاع الرايت فنتريكولار اوفرلود، دايليتد رايت فنتكل، ماكولين ساين بوزيتيف، الفلاتيننج بتاع الانترفنتريكولار سيبتم، الانفيرو فينا كيفا الدايليتد والريسبيراتوري كولابس قليل، وال66 ساين انا معلش دي هشرحها، مع الام مود التابسي اقل من 16، والسيستوليك فيلوسيتي بتاع التيشو دوبلر كان اقل من 9.5. العيان كان ده الايكو بتاعه، البلمونري فلو فيلوسيتي على البلمونري ارتري كان 57، يعني اقل من 60، الاكسلريشن تايم من البيك من الاونست لغايه البيك، والترايكاسبيد فلو فيلوسيتي كان اقل برضه من 60، كان 45، كان في مايلد اليفيتد رايت اترال بريشر، يبقى ده في بوزيتيف 66 ساين. دي مهمه لان السبيسيفيستي بتاعتها في العيان ما عندوش سي او بي دي 100%، هي والماكولين ساين اللي هو الايبكس كونتراكتنج وهايبوكاينيزيا في الرايت فنتريكولار فري وول، عشان بياخد السفيريكال شيب تو ايكولايز الرايت فنتريكولار وول ستريس من البريشر عالي اللي قدام. ثالث خطوه في المانجمنت بعد الانيشال ستابيلايزيشن وكونفيرم تريتمنت، كونفيرم دايجنوزس، ستارت ريبرفيوجن اكوردنج تو ريسك اسسمنت. يبقى تحط العين في ريسك، هاي ريسك، انترميديت، واتقسمت في 2020 انترميديت هاي وانترميديت لو او لو ريسك. اللو ريسك ده بتخرجه، والهاي او الانترميديت هاي بتعامله تقريبا نفس المعامله. هو العين بتاعنا هاي ريسك لانه كان فيه هيمودايناميك انستابيليتي، الكلينيكال بارامترز بتاع البلمونري سيفيريتي اندكس كانت موجوده، والرايت فنتريكولار ديسفانكشن كان موجود، وفي اليفيتد تروبون. ايه هي الكلينيكال ساينز اوف سيفيريتي بالمونري امبوليزم؟ انا لخصتها في 4 حاجات: تاكيكارديا، هارت ريت اكتر من او يساوي 110، هايبوتنشن اقل من 100، سيستوليك، هايبوكسيا، اكسجين اقل من 90، ومن الهيستوري ايج اكتر من 80، كانسر او كرونيك هارت فيلر او سي او بي دي. اي حاجه من الحاجات دي لو موجوده بيبقى 30 days mortality risk اكتر من 11%. يبقى العيان ده عنده هاي ريسك اوف ايرلي مورتاليتي، يبقى هنعمل له ايه؟ لازم نبدا ريبرفيوجن. ايه ريبرفيوجن تشويس للعيان ده؟ ثرومبوليتيك، سيرجري، سيرجيكال امبوليكتومي، او ترانسكاستر مانجمنت، ميكانيكال ديفراجمنتيشن، ولا نستمر على الهيبرين والانتي كواجوليشن. طبعا السيستميك ثرومبولايسيس ابسوليوت كونترا انديكيشن، العيان ده لسه عامل عمليه خلال 24 ساعه اللي فاتت، والسيرجيكال امبوليكتومي وموجود طبعا استاذ الدكتور احمد حسونه، هو غالبا بتترفض الحالات دي شوكد، ويعني لسه عامل جراحه نص سيرجن ريفيوز الاوبريشن، وده اللي حصل. والهيبرين والانتي كواجوليشن العيان ده بقاله 3 ساعات من ساعه ما بدات القصه دي لغايه ما احنا شفنا العيان كان عدى 3 ساعات على الماكسيمم ميديكال تريتمنت، والضغط اخره 90-60، ولسه العيان دراوزي وريسبيراتوري ديستريس وهايبوكسيا. فما كانش قدامنا غير الترانسكاستر ديفراجمنتيشن. والميجر تشينج اللي حصل في 2020 البلمونري امبوليزم جايد لاينز كانت انه الكاستر دايركت ثيرابي اتنقل من 2B ل 2A، وبيستخدم في كل الحالات اللي فيلد ثرومبوليتيك او ما تقدرش تديها ثرومبوليتيك زي الحاله بتاعتنا دي. واتقسم العيان لهاي ريسك، احنا عندنا هاي ريسك، هيمودايناميك سبورت وريبرفيوجن على طول. عملنا ايرجنت كاستر دايركتد ديفراجمنتيشن، وكان البلمونري بريشر بتاع العيان كان 53/32، وده منظر التكنيك اللي احنا بنستخدمها. بنستخدم 6 فرنش فيمورال فين شيس و 0.35 جي تيبت واير مع البيك تيل 6 فرنش احسن او 5 فرنش، والانجكتور و50 سي سي سيرنج. ودي الصعوبه الحقيقه الاساسيه في الدخول هو في دخول الرايت بالمونري ارتري، وده بالمانيبيوليشنز كده بتقدر تدخل الرايت بالمونري ارتري، بالذات لو اكيوت مش اكيوت اون توب اوف كرونيك. بالاكسبيرينس كده البيست تايمنج هو من 3 ل 6 ساعات بعد beginning اوف شوك، وبعد 12 ساعه من الشوك الريزلتس بتبقى not good. ده واحنا داخلين الرايت بالمونري ارتري، وبندخل بالبيك تيل وبنعمل 20 روتيشن وعلى الواير، وبنحقن بالسرنجه. في الاول كنا بنحقن حوالي 500 سي سي، وبعدين لقينا الفوليوم اوف لود عالي، فدلوقتي بنحقن 50 في الرايت، 50 في الليفت، و50 في المين بالمونري ارتري مع المايلد روتيشن رايت وليفت. الكلينيكال كورس بتاعنا، العيان بعد دايركتد defragmentation الكاست دايركتد defragmentation was successful. The patient was gradually weaned من الفازوبريسرز والاكسجين، وبعد النكست 3 days البلاد بريشر بعد 3 ايام بقى 130 على 80 130 over 80، والاكسجين ساتوريشن كان 96 على الروم اير. والانتي كواجوليشن during the first 3 days ادينا unfractionated heparin intrapulmonary، بنسيب البيك تيل في الرايت او الليفت مين بالمونري ارتري، وندي continuous intravenous infusion. اتحسن in within 48 hours، عند اتحسن بعد 48 ساعه بنشيل البيك تيل، بنكمل بلو موليكولار ويت هيبرين 60 مللي جرام كل 12، عشان كنا في فير من البليدنج، فدايما كنا بناخد اقل من يعني هو العين كان وزنه 80 بس احنا ادينا له 60 مللي جرام كل 12 ساعه. during hospital stay وكان الديسيجن امتى نخرج. لو problem now when to discharge the patient، عملنا له الليمب دوبلكس، لقينا فيه sub acute DVT في البوبلوتيال والانتيريور والبوستيريور tibial veins، والبيشنت discharged after 2 weeks على low molecular weight management heparin، و day before discharge anticoagulation rivaroxaban 20 مللي جرام per day. السؤال هنا الشيفت من اللو molecular weight for 2 weeks to novel oral anticoagulant on discharge, which strategy? The strategy we use the rivaroxaban 20 immediate or rivaroxaban 15 twice for 1 week to continue the 3 weeks loading, or rivaroxaban 15 twice for 3 weeks, whatever the duration of hospital discharge, and I believe it's a good area for research. Next is, what is the risk of recurrence? Patient now is good, ambulated. Does the patient has a risk of recurrence for VTE, low or intermediate or high risk? According to the guidelines, this patient has a low risk because he has a reversible cause, surgery, and fracture is a reversible cause for recurrence. So he has a low risk for recurrence, and it necessitates only 3 months of NOAC therapy. But after 1 week, patient presented again to the ER with acute dyspnea, with oxygen desaturation and shock, blood pressure 90 over 60, saturation gain 93% over ventrimass 60%. What's your diagnosis? It's a recurrent high-risk pulmonary embolism. And now, what's your treatment strategy? We give him a thrombolytic therapy. Now 3 weeks passed, 2 weeks in hospital and 1 week out of the hospital after surgery, so we can give streptokinase 1.5 million unit over 2 hours, and the patient improved during the next 2 days and weaned from vasopressors. But what can we do next? We put for him an inferior vena cava filter as a class 2A indication for recurrent pulmonary embolism. Is the filter put it by the vascular department, and the patient after 3 days, patient was discharged, blood pressure 130 over 80, and oxygen saturation was 95 on room air. And oral anticoagulation, we decided to give it for 1 year and re-evaluate. And this chronic or long-term treatment, indefinite duration of oral anticoagulant if recurrent, DVT is a class 1. We reduced dose of NOAC, Rivaten or Apixaban 2.5 after 6 months of treatment is class 2A, and this is what we did for this patient. My take-home message, dear chairman, is to suspect pulmonary embolism diagnosis in any patient with acute dyspnea and hemodynamic instability. stability. Once you suspected, there is 3-step management protocol: initial stabilization, confirmed diagnosed by echo and CTPA, start reperfusion according to risk assessment. Consider catheter-directed treatment in high-risk patient and intermediate high-risk pulmonary embolism who has a contraindication or failed thrombolysis, and encourage a pulmonary embolism response team set up to enhance clinical decision-making as early as possible. And I hope you can join our prospective study on hydromechanical defragmentation of pulmonary embolism. And thank you very much.
Thank you very much, Dr. Ayman. حالة رائعة وفيها messages كتيرة قوي. We want to start by Professor Atif Al-Bahri. He will comment about the case, and then Professor Dr. Karim Said. Dr. Atif.
شكرا دكتور أيمن for your presentation. Your case. طبعا الكيس دي لأي واحد فينا دي دايلما مش سهلة وبنشوفها كتير وفي اللي بيعدي وفي اللي ما بيعديش. عندي سؤال ليك يا دكتور أيمن. The major complications of CAS-directed therapy, including pulmonary artery rupture, massive hemoptysis, which we've seen in many reports, more than 3% of cases, while the hemodynamic deteriorations due to the fragmented emboli was unpredictable. You can't unpredict this fragmentation when you use the CDT. So how can you avoid this, and what's your work out to avoid what I say?
Thank you very much. It's a very important question about the complication of pulmonary defragmentation technique. As you can see in the video I put, that there is difficulty to pass by the wire into the right pulmonary artery. So if your wire pass deeply in the peripheral pulmonary artery, you will make a rupture in the pulmonary distal pulmonary circulation, and this will result in hemoptysis. So it needs experience, slow maneuver. It's a tedious technique and take a lot of time to reach inside the pulmonary arteries, especially if you have renal dysfunction. So you can't use a lot of dye to see where is your wire. This is a cause of hemoptysis. The hemodynamic response is a criteria of success of this pulmonary defragmentation. Different success rate is between 80% and 86%. Defragmentation technique success rate depend on 3 things. First, hemodynamic improvement. Patient was dying actually, blood pressure was not responding. So if he responds, this is a good thing. Oxygen saturation improve, and the pulmonary artery pressure do not improve immediately on table, but it improves within 2 to 3 days. Then after follow-up, we have a 3 months now follow-up in our ongoing trial. It markedly improved return to normal in successful cases. The main cause of this, we have 3 or actually 4 cases. We succeed to do 23 cases over 2 years now. And 3 patient dies. All had if you start doing this catheter-directed procedure after 12 hours, you have a very bad result. If you do it early, within 3 to 6 hours, maximum 12 hours, you can do it. We have good results, patient, especially if acute, not acute on top of chronic, because we have also some cases acute on top of chronic, and the results is not good in these cases.
Thank you, Ayman. I'd like to make a brainstorming for all my colleagues now, because we have stars with us. If if the catheter directed therapy is not available in my area, in this case, what you present, what shall we do?
دكتور كريم رأيك يا دكتور كريم. Very good question from Dr. عاطف. دكتور كريم, do you hear us?
معاك يا دكتور محمد. السلام عليكم.
السلام ورحمة الله وبركاته.
السلام ورحمة الله وبركاته.
بسم الله الرحمن الرحيم. طبعا it's a very difficult question، لكن لو احنا بصينا على الابسوليوت كونترا انديكيشن بتاعه الثرومبوليسيس ان بيشنتس بالمونري امبوليزم هنلاقي مختلفه شويه عن الكونترا انديكيشنز بتاعه المايوكاردال انفاركت. هم ليميتد، كلها ريليتد للبرين كلها. ولما اتكلم على التروما اتكلم على ميجور تروما وميجور سيرجري. العيان ده عمل فيكسيشن للتيبيا. I would not consider this as a major surgery. ولو حصل bleeding it is a controllable bleeding. فلو انا ما عنديش الميكانيكال thrombectomy والعيان dying and the mortality in this case exceeding 90%, I will go for fibrinolysis. لكن هستخدم بروتوكولز وهستخدم ريجيمن اللي انا انشور ان البليدنج ريسك يبقى قليل، ولو حصل I can control it as soon.
عايز اسمع من الدكتور عادل الاتربي.
هو طبعا زي ما قال كريم ان في 2 بروتوكولز حاليا. الويل استابلش بروتوكول اللي هو رابيد ثرومبوليتيك ثيرابي ب1.5 مليون، والاولد بروتوكول اللي احنا كنا ماشيين عليه زمان وانا وعاطف ومعظم الاولد كارديولوجيست كنا بندي الاول 250,000 بولس وبعدين بندي 100,000 بير اور. I think في الحاله دي السلو ثرومبوليتيك ثيرابي with good observation للوند والحاجات دي would have been better than catheter if you don't have a catheter.
Yes.
So I would recommend thrombolytic therapy in a conservative fashion or the old fashion. ببولس low dose bolus 250 ثم 100 per hour for 24 to 48 hours. And I would have done with this any patient with massive pulmonary embolism. I rather put a filter from the start. يعني ما خرجش العين من غير فلتر. Usually I do that. It's off label والفلترز لها مشاكل، لكن الماسيف embolism is a life threatening situation و I think ان ده. بس انا سؤالي لاحمد تاج بقى which يعني قصدي يعني سؤالي للجميع ايه، خصوصا طبعا ايمن الكيس دي احنا يا ريتك كنت قلت لنا نخش معاك برضو في الريسيرش من عين شمس. بس انا بسالك سؤال، ايه الكرايتيريا اوف سكسس؟ هل مثلا البلمونري ارتري بريشر ات تيكس تايم، فهل الانجكشن مثلا لما بتعمل انجكشن بالكونتراست بتشوف البريفرنس بتملى ازاي؟ دي واحد. وثم الانجكشن اوف سلاين اللي هو الكميه دي هل باي بريشر انجكتور ولا بالهاند انجكشن ثرو ذا كاستر؟ ده اللي عايز اسالك عليه.
هو الف شكر دكتور عادل. طبعا انا يعني يا باشا اتشرفنا واحنا لسه شغالين اون جوينج الترايل، يعني اتمنى ان حضرتك وكل اللي يبقى انترستد يبقى يشترك معانا، نبعت لهم البروتوكول ونشتغل مع بعض. احنا بناخد 4 بارامترز. الامبروفمنت للاكسجين ساتوريشن ده اون تيبل. الهيمودايناميك ريسبونس بيحصل خلال كام يوم، ماكسيمم 3 ايام. والهوسبيتال ديسشارج العيان يعني يخرج من ما دونت داي، ده هم 3 مين بارامترز. في بارامتر رابع بنشوف الرايت فنتريكولار ديسفانكشن برضو بيتحسن. احنا بنقيس كل حاجه، بنعمل ايكو قبل القسطره على طول وبعد القسطره وهو خارج، وبعد 3 شهور بنتابع العيان. في ناس البلمونري ارتري بريشر، لكن احنا كل الحالات ما قلش البلمونري ارتري بريشر خالص اون تيبل، لكن قل واحنا بنشيل البيك تيل. احنا بنسيب البيك تيل لغايه ما العين يتحسن الضغط بتاعه، واول ما ضغطه يتحسن نشيل البيك تيل، نمشي على الانترافينوس هيبرين. واحنا ومش كل الحالات كونترا انديكيتد ثرومبوليتيك. في عيان بنديله الثرومبوليتيك زي ما قال كريم كده، انه احنا العيان ده ممكن تعتبره انه مش سيفير، مش ميجور سيرجي، فممكن تديله ثرومبوليتيك ان ذا بالمونري ارتري، بتدي هاف دوز ثرومبوليتيك انسايد ذا بالمونري ارتري، ودي عملناها في بعض الحالات وكملنا بانترافينوس هيبرين. لغايه ما يتحسن، بعدين بنكمل بالموليكولار ويت. ده اللي بنعمله حاليا.
Thank you Dr. Ayman. I think
بس I have one comment بعد اذنك دكتور حسونه.
كلمه واحده.
اتفضل.
One comment and it's a question also.
تمام.
Do you think there is a place for fondaparinux better than unfractionated heparin in such cases of high bleeding risk? Do you think?
صحيح. صحيح. totally agree فعلا.
وخاصة الحقيقة ان احنا and I have some personal experience about the use of the fondaparinux, especially the dose of 7.5. It's يعني especially and the 10 milligram also. The 10 milligram and 7.5 according to the body weight. I think efficacy is okay, and also for those patients with high bleeding risk, I think the use of the fondaparinux will be much more safer than the unfractionated heparin. دكتور حسونه.
انا متفق مع سيادتك. اتفضل دكتور كريم. اتفضل. يا باشا. انا متفق مع سيادتك، بس it could be a subject of research very serious يعني، ونعمله يا ريت يعني. بس انا كنت عايز ارجع خطوه اصغر من كده. يعني عندنا مشكله كبيره جدا في مصر الدي في تي. يعني انا لاسباب تاريخيه ويعني بشوف حالات كتير جدا دي في تي. يعني انا عندي بيرسونال ريكوردز حوالي مثلا يمكن 10,000 عيان مثلا يعني او اكثر، جمعتهم على مدار السنين اللي فاتوا، عشرهم دي في تي لاسباب تاريخيه. الناس دي كانت بتجيلي وجيوغرافيكال يعني مش وقتها. فانا these patients are not diagnosed. يعني طبيعي ان اشوف العيان عدى على دكتور العظم ودكتور الجراحه بعد ما دكتور النساء، وجاي لي بعد شهر ونص اندايجنوز هو عنده دي في تي كويت ايفيدنت. احنا للاسف يعني اخواتنا في الفاسكولار سيرجن كجمعيه الاكتيفيتي بتاعتهم يعني لسه في الاول، ويعني في مشاكل لوجستيه معاهم كتير. جراحه بره الموضوع خالص. يا ريت انتوا الاساتذه الكارديولوجي، انتوا الناس الكبار، الناس بيسمعوا كلامكم بيعملوا اللي انتوا عايزينه، يعني ليكوا كلمه مسموعه مش بجاملكم، دي حقيقه يعني. تتولوا هذا الموضوع عندكم انتوا شويه وعي بالدي في تي. دي في تي is very easily diagnosed clinically. sensitivity of clinical diagnosis بتاع الدي في تي يقرب من 100%، والسبيسيفيستي فوق ال 90% كلينيكال حتى بين الناس اللي هم عندهم سام اكسبيرينس. فيا ريت يعني لو تقدروا انكم تتولوا هذا الموضوع مع الشركات، مع الدكاتره اللي بيسمعوا كلامكم، توعوهم شويه، لان يا جماعه كم الدي في تي اللي بيحصل غير طبيعي. لو تشوفوا كام واحد بيتجبس وبعد ما يفك الجبس بيجي له دي في تي، كام ست بتولد وبعد الولاده بيجي لها دي في تي، وطبعا البالمونري امبوليزم جاي بعد كده. فيا ريت ما اعرفش هل يعني حد من الاساتذه الكبار اخواتنا يعني يتولى هذا الموضوع، ينشر هذا الوعي. والناس طبعا خصوصا في الاقاليم فيري ايجر يسمع منكم في هذا الموضوع. انا اعتقد ده هيوفر علينا مشاكل كبيره جدا وحاجات يعني احنا مش محتاجينها.
انا عندي سؤال
موضوع الدكتور سيد، فطبعا ده فيري انترستنج سبجكت. يا ريت حضرتك تعمل استادي بخصوص هذا الموضوع، وشرفني طبعا اشترك مع سيادتك فيها باي طريقه.
كريم كان عندك كومنت؟ كريم
دكتور سيد، انا عندي سؤال للدكتور محمد سليم المودريتور. سؤال مهم يعني في معهد القلب. The absolute risk of bleeding related to intraclot thrombolysis ده individual على فكره، وكل الستاديز اللي معموله كلها والجايد لاينز اللي محطوط عليها، انا مش عارف يعني حاسس برضو ان في بايس كده بيعتمد على الاوبزرفيشن. فايه رايك في الموضوع ده؟
بايس ايه من ناحيه ايه؟ يعني اوفر استيميشن للريسك اوف بليدنج. هو الحقيقه بيه احنا لازم زي ما في ريسك اوف ثرومبوزز لاي بيشنت في الدنيا في ريسك اوف بليدنج. الحته دي بالذات في البوست اوبرتيف الحقيقه في الليترشر ما فيهاش ريسك ستراتيفيكيشن، يعني بيحطوا السيرجري وخلاص. واخد بال حضرتك؟ حقيقه كريم قال ملحوظه كويسه جدا ان تيبيال فيكسيشن انا ان ماي اوبينيون فعيان عنده 51 سنه وما عندوش apparent other cause of risk of bleeding، ما هياش ذات يعني فوبيا. يعني احنا we can give him I think in my opinion so ان هو post arrest for very high risk sudden cardiac death. فالريسك اوف ثرومبوزس is much more than the risk of bleeding. فاي ثينك ان احنا زي ما حضرتك بتقول فعلا في بعض الكلينيكال سيناريو غير بنعمل اوفر استيميشن بليدنج، غير بقى لما يكون مثلا برين سيرجري، غير لما يكون حاجه جي اي تي. لكن بالنسبه للاورثوبيديك بالذات حاجه ديستال كده وتيبيال، انا موافق حضرتك تماما ان هي ما بنعتبرهاش ان هي هاي ريسك اوف بليدنج.
ماشي
انا
كريم،
بس
ليه
بعد إذنك
كومنت
يا
كريم؟
سليم،
طيب
دكتور سيد بعد اذنك ليا بس تحفظ واحد على الحاله دي، ان الفاسكولار سيرجن هو اللي ركب الفلتر، ده اللي التحفظ بتاعي.
بالظبط
وي نيفر كول فاسكولار سيرجنز فور فلتر.
بالظبط، ده شغلكم.
هو ممكن تكون اصلا ناس معترضه على الفلتر يا بيه. رايك ايه يا كريم في الفلتر؟ رايك ايه يا كريم في الفلتر بسرعه كده عشان الوقت؟
هو انا عندي كام كومنت، لكن لو هنقتصر على الفلتر انا عايز اقول 2 كومنتس على الحاله. الكومنت الاولاني على العيان اللي جاله ريكارنت دي في تي وايل اون انتي كواجلانت ثيرابي زي الحاله دي. اللي حصل ان العيان اتركب له اي في سي فلتر and I have some concern about this. بدايه الاي في سي فلتر is not this safe procedure. كبروسيدور it has some minor complication، لكن الليتريتشر بيقول ان الريسك اوف دي بي تي increases with IVC filter and it poses no survival benefit at all and anticoagulant should be with IVC filter. الجايد لاينز بتقول احنا هنركب الاي في سي فلتر لما يكون في failure of، ونخلي بالنا of therapeutic effective anticoagulation. السؤال هنا، هل العيان ده كان واخد effective therapeutic anticoagulation؟ عشان نجاوب السؤال ده نشوف الدوز اللي هو كان بياخدها. هو كان بياخد ريفاروكسابان 20 ملغ once daily and this is not the recommended strategy في الاكيوت فيز. actually النواك في الماسيف pulmonary embolism الماسيف pulmonary embolism كان excluded من الترايلز، لكن هو في الداخل في الجايد لاينز بيزد على الريزلتس.
تمام.
فاحنا لو هندي يبقى هندي الاكيوت اللي هو 15 ملغ بي اي دي فور 3 ويكس. العيان ما خدش كده، بلس اتاكد ان العيان كومبلاينت للتريتمنت، بلس اتاكد ان العيان بياخد البيل افتر فود. احنا عارفين البايو افيلابيلتي بتاعت الريفاروكسابان انكريزز 50 to 60% with food. لو العيان ما كانش ماشي على كده ما اقدرش اسميه ان ده افكتيف انتي كواجيليشن، وبالتالي يبقى انا حصل رش للاي في سي فلتر. ايفن لو العيان كان ماشي على الريفاروكسابان in proper therapeutic dose. It is very very uncommon ان العيان يجي له recurrent pulmonary embolism وهو على انتي كواجلانت. الريلاتيف ريسك ريدكشن بتاع الاورال انتي كواجلانت في البي تي اي is 80%. ولما يكون السبب اللي عندي ريفرسبل يبقى لازم استغرب جدا ان العيان ده يحصل له ريكارنت بالمونري امبوليزم وهو على ثيرابيوتيك اورال انتي كواجيليشن. هنا لازم ادور على سبب تاني. لو هو كان كومبلاينت ادور على سبب تاني. في العيان ده واي نوت ان هو ما يكونش انتي فوسفوليبيد سندروم، واحنا عارفين ان بعض العيانين ممكن يبقى المانيفستيشن الوحيد بتاعهم دي في تي انتي بالمونري امبوليزم اند اورال انتي كواجلانت نواك از كونترا انديكيتد ان ذوز بيشنتس. لو العيان ده كان اولد شويه وعنده some features why not to be a cancer. I mean I should exhaust myself قبل ما اركب permanent IVC. واكشولي ده permanent حتى لو انا بسميه retrievable IVC. They are not being retrieved at all. الليتريتشر بيقول كده ما بيتشالوش. الفيزيشن بينسوهم او بيبقى في difficulty في الريتريفال نتيجه الفايبروزس في الاي في سي. فقبل ما اروح للاي في سي فلتر لازم اجهز كل الورك اب تو رول اوت secondary causes for البي تي اي recurrence والcompliance to the treatment and even so why not warfarin. لو العيان حصل له recurrence على نواك why not warfarin على INR 2 to 3 لو احنا بنتكلم على reversible cause of دي في تي في عيان نتيجه fracture نتيجه تروما نتيجه سيرجري. فده محتاج يعني consideration literature في نسميه poor evidence pose error للموضوع ده. ده كومنت. الكومنت الثاني في الحاله على هامش الحاله، العيان هنا اتعمل له سي تي بالمونري انجيوجرافي وهو unstable. الجايد لاينز بتقول ان العيان لو hemodynamic unstable the first step is echo. الايكو is bedside rapid and diagnostic. يعني لو انا لقيت right ventricular dysfunction او right ventricular thrombus this is pulmonary embolism. لو ما لقيتش this is not pulmonary embolism. ده على عكس اللو intermediate risk pulmonary embolism ان الايكو has no diagnostic role it is only prognostic. فانا عملت ايكو خلاص اتحل. هو اكشن العيان عمل ايكو later on لكن انا اعمل سي تي pulmonary angiography العيان hemodynamically borderline هيروح لانذر ديبارتمنت هياخد كونتراست it takes time. ف يعني الايكو ممكن يبقى هو الفيرست موداليتي، والجايد لاينز بتدينا الاوبشن ده وتخلي السي تي از الترناتيف. برضه في عيان عنده هاي ريسك بالمونري امبوليزم وكولابس، مفيش ذيس نيسيسيتي ان انا احسب بريدكشن رولز او ان انا احسب البيسي سكور. اكشولي ذيس بيشنت هاد sudden cardiac death، فهو by all means he announced himself as a high risk patient. فمش محتاجين ان احنا نعمل له ريكلاسيفيكيشنز، هو خلاص بالمونري امبوليزم والايكو اكد الموضوع ده. we can go directly for whatever reperfusion therapy. وزي ما دكتور ايمن قال دي دايمر رغم انه موجود في الالجوريزم ملوش رول، لان خلاص الكلينيكال سيناريو حط العيان ده في كونتكست بعيد خالص عن السندرومز الثانيه بتاعت اللو والانترميديت ريسك بالمونري امبوليزم.
Very relevant comments يا دكتور كريم. طبعا احنا الحاله طبعا needs separate session الحقيقه يا دكتور ايمن، حاله عظيمه، بس احنا for the sake of the time we have to thank بروفيسور عاطف البحري، we have to thank بروفيسور كريم سعيد، طبعا استاذنا الدكتور حسونه، استاذنا الدكتور عادل اتريبي. very valuable comments and we will go شكرا دكتور ايمن مره ثانيه and we will go for break for 1 minute and then we will come back for the last case. Thank you everybody.
شكرا.
حاله حلوه قوي يا ايمن، وطبعا الانتراكشن عليها يعني.
لا بس شوف دكتور عادل مش عاجبه بتوع الفاسكولار ما لهمش دعوه يا دكتور عادل. Welcome back. I really enjoy these cases and this session, and now we have the last case in our scientific day by Dr. Sharif Abdul Samad from the Medical Research Institute, Alexandria University. I think his case is a difficult and complex PCI case with the title of The Cabbage is Not the End of the Road. Thank you, Dr. Sharif, for having you with us, and we are ready to hear you. تفضل.
السلام عليكم، بسم الله الرحمن الرحيم. شكرا دكتور محمد سليم for the nice introduction. I would like to thank Professor Ashraf Rida and Professor Said Farag for inviting me to share in this prestigious meeting. My case for today is entitled Cabbage is Not the End of the Road. The patient data is a 63-year-old gentleman. He was an ex-smoker, diabetic and hypertensive. He suffered from non-STEMI 6 years ago, for which he underwent coronary angiography. He was found to have two-vessel disease, and he underwent coronary artery bypass grafting surgery with an Lima to LAD and radial graft to OM, second obtuse marginal and diagonal branches. He's now presenting with exertional dyspnea, Canadian Cardiovascular Society class 3, and he's suffering from depressive symptoms due to exercise-limiting angina despite optimal drug therapy. On examination, his blood pressure was 120/80, his pulse was 70 beats per minute, equal bilateral, with a weak left dorsalis pedis pulse. Head and neck examination revealed no congested neck veins. heart, S1, S2 heard with no added sound, slow limbs, no edema, and no signs of DVT. Investigation showed a urea of 32 milligram per deciliter, creatinine 0.9, CKMB and troponin at that time was negative. ECG showed normal sinus rhythm with a heart rate of 68 beats per minute, ST segment depression, and the inverted T waves in the inferior leads. His echo showed an ejection fraction of 56%, grade 1 with mild diastolic dysfunction, no resting wall motion abnormalities apart from mild septal flattening post-catch. His current medical therapy was aspirin 81 milligram, bisoprolol 5 milligram, diltiazem 60 milligram 1/2, enalapril, isosorbide mononitrate 40 milligram tablet 1/2, nicorandil 10 milligram 1/2, and atorvastatin 20 milligram tablet 1/1. So what is the best next step to maximize the medical treatment and follow up after 1 month? Advise the patient to undergo an exercise stress test or an exercise stress test with imaging modality to undergo diagnostic coronary angiography immediately, or advise the patient to undergo multi-slice CT coronary angio. We advise the patient to undergo an exercise imaging modality, and from this, the guidelines of the management of coronary syndromes of 2019, the risk stratification recommended in patients with new or worsening symptom levels, preferably using stress imaging or alternatively exercise stress ECG, and it is recommended to expeditiously refer patients with significant worsening of symptoms for evaluation. The patient underwent exercise myocardial thallium perfusion imaging. The test was terminated due to chest pain. Analysis of wrist stress images revealed moderate inferior infraceptor and infralateral ischemia with viable myocardium. We can see here the areas of ischemia. This is the rest and the stress. Here also, and in the inferior. So, what is the next step? Best step? Optimize medical treatment and follow up after 1 month. Advise the patient to undergo diagnostic coronary angiography with view of intervention. Or advise the patient to undergo multi-slice CT coronary angiography, or refer the patient for advanced refractory therapies like enhanced external counterpulsation or now the new coronary sinus reducer. So we advise the patient to undergo diagnostic coronary angiography with view of intervention, and also from guidelines of myocardial revascularization. For disease progression, late graft failure, it is recommended repeat revascularization indicating patients with a large area of ischemia or severe symptoms despite medical therapy. So diagnostic coronary angio through right transfemoral approach using GL4 and GL4 6-French catheter revealed the following. This is the left system. We can see left main was okay. The LAD shows post-DL 80% lesion with total after followed by nearly total occlusion. The LCX showed proximal to mid total occlusion. Sorry. This is another view, the left system. The right system was the same like in the old diagnostic coronary angiography. It was non-dominant and significantly or diffuse the diseased vessel. This is why there was no grafts for this vessel at the time of CABG. The grafts, the radial graft to the second OM and radial and diagonal branches was widely patent. This is another view. And the Lima graft was patent with good distal anastomosis. So what is the best next step? Continue current medical treatment and reassess after 3 months. Refer the patient for redo CABG surgery. Refer the patient for advanced refractory therapies or proceed with ad hoc PCI LCX. We actually proceeded to ad hoc PCI LCX. According to guidelines of myocardial revascularization, we see that indicated in patient large ischemia or severe symptoms despite medical therapy. If considered safe, PCI should be considered as first choice over CABG, and for PCI distal protection should be considered if we are doing PCI for saphenous graft lesions, and PCI or bypass native arteries should be considered over PCI of the bypass graft. So we did PCI run through intermediate PCI wire was used to cross the CTO with the aid of a UK6 PTCA balloon catheter, which was used for pre-dilatation several times. This is after the first pre-dilatation. A larger balloon was used then, a 2.25 Medisonic balloon was used for further pre-dilatation of the totally occluded mid-segment of the LCX. And this is the result, then we proceeded to stenting of the mid-LCX using design 2.5 by 38 millimeter stent. This is stenting, and this is the post-stenting result. We did also post-dilatation using a Medisonic NC 2.5 by 15 millimeter balloon several times up to 16 atmospheres. During the post-dilatation and even after stenting, the patient suffered chest pain, but was not very tough chest pain. And we saw that there was a missing early OM branch. So we started probing the area of this OM branch with a run-through floppy PCI wire. And luckily enough, the branch opened spontaneously with no further intervention. And these are the final images. So my take-home messages is patients with new or worsening symptoms after revascularization should be promptly investigated. The use of imaging stress modalities helps to determine the site and assess the burden of ischemia. Repeat coronary angiography is indicated based on symptoms and the results of non-invasive tests. PCI of the native vessels, if technically feasible, is the post-CABG intervention of choice, and CABG is not the end of the road. Thank you very much for your attention, and hope to see you all in person in good health soon, inshallah.
Thank you very much, Dr. Sharif, for the great case. I want to of course, by the head and president of the working group of intervention, Professor Aidel Trebi. He will give us his feedback about the case. Professor Aidel.
Okay, شكرا يا شريف for the interesting case. بس أنا الحقيقة الصور بتاعت النيتيف فيسلز والجرافتات كانت سريعة قوي، فأنا ما قدرتش أعرف إذا كان الجرافت of the circumflex was patent or not.
Yes, patent. It was patent. It was a radial graft, a free radial graft to the second obtuse marginal and diagonal branch. It was like a jump graft, and it was widely patent with good distal anesthesia.
هو كان لسه في study لسه طالعه امبارح comparing النيتيف coronary intervention versus الجرافت intervention. هنا طبعا الوضع مختلف لانها طلعت interesting قوي ان الجرافت intervention is better than native intervention against كل الرولز اللي احنا متعودين عليها. يقول لك الجرافت ده ارميه في الزباله، اشتغل على النيتيف فيسلز احسن، خصوصا في سي تي او. الاستادي دي لسه طالعه امبارح بتقول ان الانترفنشن في الجرافت افضل من الانترفنشن للسي تي او اوف ذا نيتيف فيسل. السيتويشن هنا مختلف شويه لان العمليه معموله للسكند او ام، وعندك انت لارج سيركمفلكس ولارج فيرست او ام، والاثنين دول ديزيرفز انترفنشن. اللي انا عايز اقوله بس حاجتين. الحاجه الاولانيه ان في سي تي او صحيح انت يور لاكي ان الدنيا مشيت بسلاسه، لكن يو شود فولو ذا رولز اوف سي تي او اللي هي بتدخل الورك هورس واير وعليه مايكرو كاستر، ثم تدخل الوايرز ديديكيتد فور سي تي او، ثم تو بروسيد بعد كده وتشينج الواير للواير الورك هورس تاني. يعني فينا رولز. طبعا وي ور لاكي انف ان الواير العادي عدى، وسام تايمز ده اللي بيحصل او مش sometimes، ده اللي كان بيحصل زمان. كلنا كنا بنشتغل عادي بالواير وبيعدي وكل حاجه. ف for teaching purposes CTO interventions we should follow the rules of intervention عشان نقلل الفيلير ريتس. التكلفه بتاعت المايكرو كاستر عاليه، فساعات بنستخدم اوفر ذا واير بالون بدل مونوريل. فالاوفر ذا واير بالون بتشتغل اكنها مايكرو كاستر، بندخل الواير العادي ويقف عند الستامب، ثم ندخل البالون ونغير عليها الواير. لكن الحقيقه السكسس بتاعك كان جميل، ان يو ور لاكي انف انك تعدي للفيرست او ام. وساعات كتيره بيحصل زي ما انت عملت كده يا شريف، ان جاست مانيبيوليشنز كده بالواحد حتى من غير ما تخش البرانش، مجرد واحد يقعد يلعب بالواير يلاقي الفيسل رجع تاني. اللي انا مستغرب له السيمتومز، the symptoms of the patients were not matching the situation of the patient himself, because you have two patent grafts, one to the diagonal and a second OM, and you have also a patent Lima, as I understand, right?
Yes.
So just having an occluded circumflex doesn't make sense for this kind of symptoms. This is one thing. The other thing is that post-CABG angina, by definition, is an unstable angina.
Yes.
So one of the definitions of unstable angina, post-CABG angina. So you should consider this as a post-CABG, as an unstable angina. So stress here, you might have some limitations of stressing a patient post-CABG, because sometimes this can cause problems. So I would rather do a CT. CT will show you the grafts, so we'll not have time in manipulations, and at the same time will give you the proper diagnosis. These are my comments, but what's more important is the success, and this is a very successful case. And I think the patient is asymptomatic now?
Yes, yes.
Okay.
Thank you, Professor Adil. Also, I'd like to welcome Professor Ritu Mitra from England. Welcome, Professor Mitra. Nice to have you here in CardioGo. And I want to hear from you. Did you attend the case from the beginning, this post-CABG case intervention? Did you see it from the beginning?
I missed the beginning. Thank you for having me. It's a great honor, to be here. I missed the beginning, but I saw the end. The result was excellent.
Okay, we have a patient with a status post-non-STEMI. He did the CABG, and Dr. Sharif did for him coronary angiography, and he opened the LCX, the native LCX, because the graft was patent for the OM and diagonal. It was a jumping graft, and the Lima was okay. One of the challenges in non-STEMI post-CABG that we don't necessarily can identify appropriately the culprit lesion, and this is sometimes is a dilemma sometimes. Of course, some angiographic features can help, but not always. Dr. Sharif, I have a question here. You have a patient with non-STEMI, okay? And I think the indication for doing coronary angio plus minus PCI is straightforward. I don't know why you go through the stress imaging and myocardial perfusion and so on. I missed this point, please.
Yeah, because the non-STEMI occurred before he did the CABG. He is now presenting with what was called the chronic stable angina.
Okay.
But the non-STEMI was before the coronary angiography, the first coronary angiography and the CABG.
It's an old history.
Yes. But now he was presenting with what we call now a chronic coronary syndrome. He's post-revascularization, and he's presenting with worsening chest pain until reaching Canadian cardiovascular class 3 angina. So that is why we went through the diagnostic algorithm and went through stress imaging.
But if we have class 3 angina, it's a crescendo angina. I think also
we could do that, but
a good candidate for exercise stress imaging.
I just wanted to localize where is the ischemia, because he is to intervene at that point and to see the extent of angina. It was a moderate, not a large area of ischemia, but still the patient's symptoms were very, very high. He was optimal medical management. We can argue that he's in a low dose of statin. This is the only thing that we can do for him and increase the dose of statin. But he was on 3 anti-angina drugs and still he's having angina. And this limiting angina, exercise limiting angina, was causing depression. He was actually depressed, and he was going to a psychiatrist for this depression. So we saw that despite the moderate area of ischemia, we still underwent coronary angiography with intervention.
Okay. Dr. Said? Unmute, please, Professor Said. Unmute, please.
Karim, I think you want to comment. I see you want to comment, Dr. Karim.
Okay. Thank you, Dr. Sharif, for your presentation. My comment is related to the strategy of testing these patients. He is coming with refractory angina on 4 anti-anginal medications. So the strategy is to do coronary angiography. This should be the strategy. Whether to this preceded by MPI to localize the site of occlusion or to localize the effusion during case using FFR or IFR, we can discuss. But the strategy in this patient should be invasive cardiac catheterization plus revascularization with or without preceding MPI. This is the point. The second point, despite being a chronic stable angina, of course, this is not an ischemia patient. He has a CABG, so there is no role for talking about optimal medical therapy. And he also has a refractory form of angina. The third issue, it would be very helpful to revise the old angiogram.
Yes, we did. I did that, yes.
Because before, this patient with this symptom is very likely to have a progression in the native vessel. When graft occludes, it occludes either silently or with acute coronary syndrome. Having this long-standing crescendo angina talk about native progression of the disease, and a reference index coronary angiography would be of help to guide the revascularization.
We saw it, but it's unfortunately not available with me.
Thank you.
You're welcome.
Thank you, Dr. Karim. Thank you, Dr. Sharif. I think we reach now to the end of our meeting. I want to thank again the distinguished panelists, Professor Adil Itrapi, Professor Atif Al-Bahari, Professor Ahmed Hassouna, Professor Karim, Professor Noumani. Thank you, Dr. Ashraf Reda, of course, Dr. Said Farag, the head and founder of these meetings. And also, I think the great presenter for the great cases, Dr. Ahmed Tag, Dr. Ayman Khairi, Dr. Sharif, and I'm happy to have today Professor Ritu Mitra. Unfortunately, he joined us a little bit late this time, but he will promise us to have him early next time. Welcome. It would be a good start, and we will see you in the next meeting. Thank you, everybody. Thank you, Professor Said, and here's your final words. Thank you.
It's a very nice ICS-1 integrated case scenarios, and I invite you all to smile to take the ICS photo, the ICS photo, and let's smile. Thank you very much, Professor Adil Itrapi, Professor Karim, Professor Atif, Professor Salim, Professor Sharif, Professor Hassouna, Professor Ayman, Professor Tag, and finally, we are waiting for the challenge with Professor Ritu Mitra in the coming session. Let us smile. Okay.
Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody. I am Walid Ammar from Cairo University. It's my pleasure to moderate a very important session and very important meeting, Cardigo, under the supervision of our dear friend, Professor Dr. Said Farag, and IAVA, Professor Dr. Ashraf Reda. In this session, we are going to have three important and very beneficial cases with a lot of tips and tricks from three elegant presenters from Egypt and from UK. It's our pleasure to have our guest, Dr. Rito Mitra from UK. It's our pleasure, sir. We have my dear friend, Dr. Ahmed Bindari, and my dear friend, Dr. Rashid. We are going to enjoy their cases. We are going to have a very fruitful discussion because we have an outstanding panelists. We have our dear friend, Professor Dr. Gamal Abu Nasr, Professor Dr. Yasser Huzayn, Professor Dr. Khalid Tamam, Dr. Mahmoud Fawzi, and Dr. Sharif. And for the sake of the time, we have to go directly into cases. And it's my pleasure to present my dear friend and younger brother, Dr. Ahmed Bindari, a rising star from Banha University, who is going to have this case with a nightmare and how we can go through this case. Please, Dr. Ahmed Bindari.
Thank you, Professor Walid, for this nice introduction. I hope that
we have to go directly into cases, and it's my pleasure to present my dear friend and younger brother, Dr. Ahmed Bindari, a rising star from Banha University, who is going to have this case with a nightmare.
Please, Dr. Gamal Abu Nasr, to mute the mic. Thank you, Professor Walid, for this nice introduction. I hope we all mute the mics, please.
And it's my pleasure to present my dear friend and younger brother, Dr. Ahmed Bindari, a rising star from Banha University, who is going to have this case.
Dr. Gamal Abu Nasr. Hello, Dr. Gamal. Can we mute the mic? To mute the mic. Thank you, Professor Walid, for this nice introduction. Hello, everyone. I hope that the screen is okay, shared. The screen is shared, okay? Okay. Today, I'm privileged to present a case during coronary intervention, which is rarely encountered. You might encounter 1, 2, or at most 3 cases during your entire career. I prefer to select strategically this title, Successful Procedure. Do you think? Think again. Because many times you think that your procedure is successful and all the room is happy, the doctor, the nurse, and even the patient. And then you get a very bad call from your colleague resident, or you get a surprise after a few hours of the intervention. First, I'd like to give little thanks to the team, which is not sufficient for them. Dr. Muhammad Magdi, Dr. Amr Madi, Dr. Abdurrahman Abu Shok, who is now in Harvard University in Boston in the United States, and Dr. Muhammad Salim. We succeeded to publish this case in the journal, Coronary Artery Disease, which is one of the interventional journals and influential journals in the field of coronary intervention. Let's start directly by Emil, who is 48 years old. He is diabetic, recently diabetic for 6 months, with no other significant past medical history. He presents to us with acute chest pain 12 hours before coming to the ER. Clinically, he was a little bit stable with blood pressure 130/80, pulse 100 beat per minute, regular, with unremarkable other examinations. This was his ECG, which showed an evolving acute anterior wall, specifically anteroseptal myocardial infarction. So we referred him immediately for emergent coronary angiography in preparation for primary PCI. And as we see, and I hope that the video is streaming well to you all, the LED is occluded very proximally, so we have to intervene. Primary PCI to the LED was done using 6 French EPU 3.5. We inserted a floppy wire,
followed by repeated balloon pre-dilatation using 2.5 by 50 millimeters balloon. And then we ended by inserting 2 overlapping DES, one distally 2.5 by 18 millimeters and one proximally 2.75 by 22 millimeters. And as you see, these are the consequence of the primary PCI procedure. Excuse me, the screen shared has stopped. I'll open the presentation again. Okay. 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 And this was the final results of our primary PCI procedure. Clinically, everything was good. No chest pain, the blood pressure was 130/80, the heart rate was 90 beats per minute and regular. But what do you see? Is this a successful procedure with STEMI-free flow as we see? Is there something which is wrong? Or do you need another view? I'll leave about 10 seconds for the audience to vote in the questions and answers and to think about it. We think that something is wrong. Oh, what's this? If you bend to the distal vessel, you will see something is going in an abnormal direction. This is not normal. But what is the best next step to deal with this abnormal streaming of the dye at the distal end of the LAD? Do you wish to do close clinical observation in the CCU? Do you wish to bring the echo and to perform an emergent bedside echocardiography? Nothing is required. I think this is a coronary cameral fistula, and it wasn't evident because the LAD was occluded in the early beginnings. I leave about 10 seconds for you all to think about what is the best next step. We thought that the best next step is an emergent bedside echo because this may be a distal wire coronary perforation. And this was the results of the bedside echo 5 minutes later with blood pressure dropping down to 90/60. We had a thin rim of effusion. So we are in front of a case of a coronary perforation, mostly a distal wire-induced perforation during primary PCI for this anterior STEMI. But what type of coronary perforation do you think that this is? Is it type 1, type 2, or type 3, type 4, or type 5? I leave you 10 seconds to think about it. For anyone who knows what are the types of coronary perforation and what is its classification, he or she will answer that this is type 5 coronary perforation. Let's speak a little bit about the classification of coronary perforations. Coronary perforations are classified into 5 categories. Type 1 is just an extraluminal crater without extravasation. Type 2 is just a pericardial or myocardial flush, again, without contrast jet extravasation. Type 3, which is the most serious type, is an extravasation through a perforation which is more than 1 millimeter in diameter. Type 4, which is sometimes called type 3 cavity swelling, in which we have a perforation into an anatomic cavity, chamber, or even the coronary sinus. And finally, type 5 coronary perforation, which is ours, that is the distal wire-induced perforation. Mostly, the distal end of the PCI wire inadvertently went out of the very distal LAD during the procedure, and this has passed unnoticed. If we look to the algorithm for managing patients with type 5 coronary perforations, we will see that we have initial steps. We should evaluate whether the patient is stable or with hemodynamic instability. Be careful that this type of perforation might occur even several hours, 9 hours, 10 hours after the intervention. Anyway, if you have hemodynamic instability, please stop and call for help. You cannot do everything by yourself. Call the surgeon, call the anesthesia, call the echo, as we did. Anyway, we should immediately, the first response as the surgery responds to the hemorrhage by compressing, our first response to distal wire perforation is to inflate a balloon just proximal to the site of perforation at low pressure, not more than 8 atm. Be prepared, please, for pericardiocentesis, and take care if you have a perforation in a bypass graft, because this may induce a hemothorax. Then check after 5 to 10 minutes, and you might have a seal perforation. But what to do if we have what we call failure to seal? First, please consider injecting thrombin or microcoil or even fat embolism or even clotted autologous blood from the patient. Please consider that if the perforation is in the distal branch, consider a covered stent in the main branch. It may occlude the side branch. Please consider reversing the heparin, but beware to retrieve the wire and all instrumentation before reversing heparin. And finally, check if you have failure to seal. You should check for collateral perfusion that may lead to failure to seal, and this, I think, may invite the surgery to the theater. Anyway, we inflated a distal 1.5 by 12 balloon for 10 minutes. The perforation was sealed, as we say. Control angio 5 minutes later. The perforation was still sealed. The patient stable and transferred to the CCU. The big surprise is that 20 minutes later, the blood pressure dropped again to 80/40 and the patient became distressed, and we have a larger amount of pericardial effusion and impending tamponade. So we had to bring the patient again to the cath lab. We did coronary angiography and we saw that the perforation had recurred. This is a bad situation. Okay, we rapidly did the pericardiocentesis, as we see as the pericardial sheath, and then we did a prolonged reinflation of the balloons that extended up to 20 minutes, and we were fortunate enough that the patient tolerated all these prolonged inflation. And final results, what we were lucky to have the perforation sealed, the patient was with no symptoms, the blood pressure rose again to 110/70, and the heart rate was 88 beats per minute and regular. And as we see, and I hope that the video is streaming well, is that the perforation is well sealed with no recurrence. But the critical question is, what's the post-procedural care and when to withdraw the pericardial drain? Ideally speaking, you should do aspiration or even depend on the passive gravity for 24 hours. And if you get less than 50 cc of the fluid every 12 hours, you are allowed to withdraw the pericardial drain. 12 hours later, patient was still stable. The blood pressure was 120/80. The heart rate was 80 beats per minute. But we had still blood leakage from the pericardial sheath. We were afraid of ventricular restoration or perforation. As we know, the patient was unlucky, and we know that all unlucky things come together. But we bring the patient back to the cath lab, we injected dye into the pericardial sheath, and we were fortunate that the dye did not spill into any of the ventricular cavities. Cardiothoracic surgeon also, we consulted him. He ordered a CT chest with contrast injected into the pericardial sheath. As we see, this contrast is confined to the pericardial cavity with no ventricular spilling. And we, after confirmation that the contrast was confined to the pericardial cavity, we were allowed to remove the sheath safely. And then the patient, few days later, was discharged in a good health. My take-home message, and this is a very important slide because it sums it all. Coronary perforations are rare. This is a rare entity, but this is a nightmare of complication, especially if you are dealing with acute coronary syndrome like STEMI. You should give high attention and to examine your control film and to bend to the distal vessel, because this complication might pass unnoticed, and then you might get a very poor call from your resident colleague telling you that the patient is collapsing. Give attention and see your tip of the guide wire. This may be your unfortunate upcoming enemy. Please watch for it. The most important 3 steps are: number 1, prolonged balloon inflation. This should be your first response. In the distal wire perforation, inflate the balloon proximal to the site of perforation or the presumed site of perforation. For example, in type 3 perforation, which is an extravasation of dye through a large perforation, inflate the balloon at the site of perforation. Then you may consider heparin reversal after retrieval of your instrumentation, and then you should be prepared anytime for pericardiocentesis. Finally, a team-based multidisciplinary approach is paramount. You cannot deal for everything by yourself. The first step, again, with prolonged balloon inflation, if you have a coronary perforation, is to call for help. Thank you.
Unmuted, Dr. Walid.
Yes. Thank you very much, Dr. Ahmed Bendari.
Thank you, Dr. Walid.
Case, as usual.
Thank you, Dr. Walid.
Now we have about 10 to 15 minutes for discussion and comments from our great panels today. But let me ask you a question before going to the panelists, Dr. Bendari. What was the type of the guide wire during this primary PCI case that ended up with coronary perforation?
I think it was an ordinary workhorse floppy wire, I think. The exact type or the trademark of the wire is not with me, but I think it was a workhorse floppy wire.
This question, because it is not
yes.
frequently encountered problem to have perforation during primary PCI. As you said, we use workhorse wires, which are floppy wires, unlikely to induce coronary perforations. Let's start with Dr. Gamal Abu Nasr. What would you like to comment, Dr. Gamal, about Dr. Ahmed Bendari case? How to avoid this type of perforation during PCI, Dr. Gamal, please. Unmute, Dr. Gamal, please. Dr. Gamal, you have on the lower left corner mute sign. Hussain, Professor of Cardiology at Ain Shams University. What would you like to comment, Dr. Yasser, and how to avoid such complication during primary PCI or PCI in general? Please, Dr. Yasser.
Thank you, Professor Walid, and thank you, Dr. Ahmed Bendari, always amazing as usual.
Thank you.
I think we have some, as Dr. Walid said, it's not an ordinary situation to see distal wire perforation in a setting of acute coronary syndrome, because we don't have a very complex lesion, calcification, a lot of resistance, exchanging wires. Thank you, Professor Walid, and thank you, Dr. Ahmed Bendari, always amazing as usual. I think we have some.
Okay, Dr. Yasser, go ahead.
Okay, so before I listen to your reply or what's your explanation for this, I think we all should be aware, for the juniors who are with us, to have a view that allows you to see the area or the geographic area you are dealing with and the distal wire as much as you can, because of course you go for orthogonal views and different views, but it's very important. And if not, try to have a look every now and then and instructing the assistant to fix the wire as much as can. The wire should not be in a side branch with abnormal position. If we went with the polymer wire just to exchange it when we finish, it's not the case here, of course. But what is the scenario happened in your explanation? What happened? Because all of a sudden we saw a perforation, which is not usual in that clinical setting.
I think that the tip of the wire inadvertently proceeded distally, and the operator for a few seconds did not notice that. This was sufficient enough to cause this distal wire perforation, and this was the basic tip which all of us were given in the initial days in the cath lab. Please have two eyes, one of the guide wire, one of the tip of the guide wire, and the other eye on the tip of your guiding catheter. I think this was the event that happened and have led to this distal wire perforation.
Okay. Thank you, Dr. Yasser. Thank you, Dr. Bendari. Dr. Gamal, you hear us? Okay. Dr. Rito Metra, you hear me?
Yes, I can hear you.
Yes, okay. Dr. Bendari left a sheath in the pericardium and flew still to come through the sheath. And despite that, they did CT chest, and after that, they removed this sheath despite having still effusion in the pericardium. What is your opinion in leaving a sheath versus a big tail catheter, and when to withdraw this sheath, and finally when to call for surgical intervention? Please.
First of all, congratulations on safely negotiating this patient's journey. Well done. I just want to say, first of all, I don't think you could have done anything about the wire perforation. I think it was bad luck. If the artery is occluded, you put the wire down, you open up the artery. There is no way you will know where exactly the distal tip of the wire is. You're using a workhouse wire. It's got a soft tip. I think this was bad luck, and I don't think you could have avoided it. I think this is going to happen in one in every 500 cases, in primary PCI, and you are going to have to deal with it, and you dealt with it in a very nice fashion. I just want to go through it step by step in what you did. So number one, you inflated the balloon, and you left it there, and that seemed to have worked. And again, when you took the final shots, the perforation had sealed. And I don't think there was anything more that you could have done. You've got the patient on the table. You did an echocardiogram. You showed that there was an effusion. You waited for a while. You sent the patient to a safe place to be monitored. And when the blood pressure went down, you did another echocardiogram that showed the effusions recurred. Naturally, the patient had to come back into the cath lab. And again, you managed to seal the perforation, and you got a pericardial drain in quite promptly. And immediately there was a good response. And I think it makes sense to leave the pericardial drain in for at least 24 to 36 hours because you never quite know. And of course, we know that you get at least 100 mils of pericardial fluid, per day. So you will get a small trickle, and it might be a little bit bloodstained. But again, you did things by the book because you weren't sure whether the right ventricle had been lacerated in trying to put the pericardial drain in. And, these things are actually not uncommon. If you have one complication, the chances are you will have a second one because the patient has become a bit more unstable, and then trying to do another procedure carries a slightly higher risk. So one complication leading to another actually is quite common. And again, I thought you dealt with that very, very well. And you even proved that there was no laceration. You injected a small amount of dye, there. You could have used a variety of methods. You could have used some agitated saline with echo contrast, whatever it is. But I think it makes sense to leave the drain in 36 hours before you take it out. I think that was a safe thing to do, and you had a very good result in the end. And I don't think you could have done much about that perforation. So.
Okay,
thank you.
Regarding the drain type, Dr. Mitra, would you recommend leaving a cheese or a pigtail catheter, or no difference?
We usually use the pigtail catheter, a pericardial drain. So about 4 or 5 years ago, we started our CTO program. And when we started our CTO program, we had a lot of perforations, and we learned how to deal with them, and we run. So to us now, they are relatively common. And we have a whole, SOP of how exactly to deal with them. And most of us have become quite good at dealing with them using, the ping pong guide technique, etc. If the perforation is large. And we've now got a set of coils kept in our cath lab, especially on our CTO trolley to deal with these conditions. But again, as you said, you can use some fat, you can use whatever you like to try and seal it. And I thought you did very, very well.
Dr. Khalid Tamam, are you with us? If you hear me, Dr. Khalid, what's the difference of coronary perforation in native arteries versus coronary perforation after bypass surgery? I think you hear me, Khalid. Dr. Khalid Tamam, if you hear me, I asked you about the difference of coronary perforation in native arteries in patients without bypass surgery before versus as you do a lot of PCI cases and CTO post-CABG. And of course, you encountered a lot of cases with perforation. How you find difference in incidence of tamponade, type of tamponade in cases post-CABG versus those without CABG before, if you hear me. Dr. Yasser Hussain, how to deal with antiplatelets if this patient was bleeding and the bleeding refused to stop? How to balance, how to compromise the safety of the stent or the safety of bleeding?
Unmute, Dr. Yasser.
Dr. Khalid came, just to answer, and then myself.
Can you unmute Khalid?
Yeah. Now I can answer the question, or
yes,
go ahead. So I don't hear the question very well, Walid, but I would like just to comment in 3 points with the wire perforations. First of all, congratulations, Dr. Ahmed,
Thank you,
this
Dr.
nice case.
Thank you.
As Professor from UK has mentioned, it's happened to anyone. It's very rare, but sometimes happen because of unluck. I don't see very well the perforation. That kind of huge perforation can cause this kind of pericardial tamponade later on. But sometimes we have to, as a technical part of our job, we have to take care about three things. as Dr. Wahid say, which kind of wire. Usually, I know that a lot of people in Egypt they are love to work with PT2MS, and this is why one of the major catastrophic wire has been used to be in the especially in the primary PCI, because this is a very tough hydrophilic wire, and they remove it distally to the artery, and I saw one of the mortality has been done without saving as you save your case. Second one, when they are pushing the balloon during the PCI to push the thrombus distally, they push the balloon very distally, and with this very small distal artery, small disease vessel, sometimes the balloon without the wire has been perforated itself. The third thing, the amount of anticoagulation has given to these patients, we don't know. Sometimes coming from other hospital has been receiving thrombolytic therapy, and then you don't know the information, and you hello? Now you hear me?
Yes, go ahead.
Yes, we hear you.
This is a 3-point always has been. I have one case was also unlucky case. Patient he don't know that he had a restrictive pericarditis. Old man, and he came for primary PCI, and after we finished the procedure without any kind of perforations, we find that patient has a severe tamponade, and I tried to make a pericarditis for him, and it was successful at that time, but very difficult. I don't feel that it's good. And then he has been saved at that time. Later, after during the ICU admissions, patient developed atrial fibrillations, and and it was anticoagulant. Have you heard me? Sorry for.
We hear you.
Yes. Yeah, and finally he came after 2 months with again pericardial effusion, massive pericardial effusion, and at that time we was unable to put a big tail for him. This unusual as well, and we did for him an MRI. We find he has a restrictive pericarditis, and the surgeon has been successfully removed the pericardium. So this always the point we have to put in consideration, as we don't see clearly the perforation, because distal wall perforation is very difficult to see it. Sometimes it's a huge one, and you can see. But Ahmad, of course, he has been managed very well, and he don't give a lot of contrast, so he don't give us a good picture. But it's good for the patients.
Thank you, Dr. Khalid, for very valuable practical comments. Final comment for this case before going to the next case was asked to Dr. Yasser Hussein, if he can answer.
Dr. Gamal is on now. Dr. Gamal, you hear this? Dr. Gamal? Not yet here.
Okay, Dr. Said, for the sake of the time, we'll go to Dr. Yasser as a final comment for this case. How to manage
a very quick comment at first, that we should stick to the algorithm to inflate the balloon, to give IV fluids and the pressures of the patient in hypotensive state. We should go for pericarditis if the patient has paradoxis or significant hypertension, and we should notify the surgeon. We should go for the algorithm. The main important thing is to reverse or to go for the anticoagulation.
أنا عندي مشكلة إنه أنا مش سامع صوتهم.
طيب من فضلك يا يسري خليك اوفلاين مع الدكتور جمال to fix his problem please، واعمل له ميوت لغايه ما تحل المشكله دي يا يسري من فضلك. اتفضل دكتور ياسر.
But please, I want from Dr. Mitra and from Dr. Khalid, because they work in CTO a lot. What about I have a quick question as regard the perforation when we deal with coil. We know that coils like Azure and other coils are poly-jacketed, and it swells by time 10 to 15 minutes. When we can say that it's okay now. This is a fair amount to leave it, and the swelling of the coil will resolve the problem, and the perforation will be sealed. What is the line of demarcation? When to leave it? It's the gush of the blood, the type, the amount of the pericardial effusion. What to do if you put a coil?
Thank you. I think in my personal experience, I may have to use more than one coil because I may have to use 3, maybe 4 coils and leave it. But I don't leave the cath lab, and I leave the patient on the table and wait. And then I may have to wait 5 minutes, 10 minutes, and then take a picture. And until I'm absolutely satisfied, I don't leave and I don't conclude the case. Because the worst thing you can do is go home, and then you get a call again from the resident saying,
when you're asleep, 8 hours later, yeah.
It's better to invest in that initial time before you.
Do you use contrast echo in some cases?
I'm sorry, I'd missed that.
Do you use contrast echo to judge properly in some cases, or you don't? You need it infrequently.
And we don't usually use the contrast echo unless we are putting in the drain. But otherwise, we don't have to do that.
Okay, it was amazing to have a case of acute myocardial infarction with primary PCI, and all the discussion went through coronary perforation. I expected this discussion to be in the case of Dr. Tariq Rashid with the CTOs, a lot of technical difficulties, especially we have another pioneer, Dr. Khalid Tammam, to have some benefits from his experience, and Dr. Tariq Rashid in his field. Actually, we'll have some questions related to perforation in the setting of the CTO, because most difficult types of perforation are those in this setting, because you have collaterals from both sides, and the story does not end by occluding one side. Dr. Khalid, make sure, and you and Dr. Tariq, that you are going to answer some of these questions regarding perforation in the setting of CTO intervention, especially post-CABG in the case of Dr. Tariq Rashid. Now we come to the end of this very, very, very amazing and in case Dr. Ahmed Bindari. We enjoyed it very much. I would like to thank him again very much. I would like to thank all the panelists for their great comments, great discussions. We had a lot of benefits from this discussion. And after 30 seconds, we'll go to the next case. Our guest today from UK, Professor Rito Mitra, will have his case. It's our pleasure after 13 seconds. Welcome back, my dear friends, my dear colleagues, our great panelists today. And now we move on in this very interesting session with the second presentation from my dear friend, Dr. Tariq Rashid, Professor of Cardiology at Tufts University. Tariq is a well-known figure for CTO intervention. He usually amazes us with difficult cases, sometimes with difficult complications. We hope this case go more or less straightforward. Please, Dr. Tariq, go ahead. The floor is yours.
Fortunately, we don't have a complication in this case, but it was a very difficult case. I think the title is suitable for this case. It's a mission impossible. This patient is a 31-year-old male patient. He had a familial hypercholesterolemia with his LDL exceeding 600. And he was a former smoker. He underwent coronary artery bypass grafting while he was 21-year-old. So 10 years before this angiography, he had bypass grafting with Lima to LAD and right mammary to obtuse marginal and saphenous vein graft to the right coronary artery. He was angina-free. Till 1 year back, started to complain of exertional angina. He had scintigraphy testing before this angiography showing a moderate defect in the territory of RCA. You can see that his laboratory tests, apart from the severe hypercholesterolemia, is normal with a normal GFR. His ECG is normal, echo normal with an ejection fraction of 67% and no regional wall motion abnormalities. He had a CT angiography, coronary angiography. This CT showed extensive disease in the native coronaries with an ostial RCA extensive disease and patent lima and rima to the obtuse marginal with occluded saphenous vein graft to the RCA. He had a coronary angiography in another center, showed the patent lima to LAD and patent rima to obtuse marginal with occluded saphenous vein graft, and they couldn't reach the ostium of the right coronary. We prepared this patient by femoral access with a right 7 French, and we used 2 Judkins right, one 3.5 for the lima and one Judkins right 4 for the right coronary. This is the equipment used in this case with the fine cross microcatheter, 150 centimeter, and we use a double lumen microcatheter, which is Sasuki dual lumen microcatheter from Asahi. And this is the wires used. Of course, this is only types of the wire, not the number. You can appreciate that we used 3 Astato XS20, and we used 5 Conquest Pro 12 and 5 Gaia third wires. And I think 2 or 3 Sign Black and 1 Fielder FC or 2 Fielder FC. So this is not the actual number, but this is the types. This is the angiography of the left system. You can show the you can see the extensive disease of the left main, and giving only small branches and no LAD. Circumflex is diseased, and both receiving patent grafts. And we try to see the ostium or try to reach the ostium of the right coronary. We couldn't identify the site of the ostium of the right coronary, and what you see on the right side is the occluded saphenous vein graft, and there is no ostium for the right coronary to reach. This is a patent nice lima to the distal LAD, and LAD is a relatively small, not large vessel, giving collaterals, both septals to the right coronary and epicardial collateral from the apex. If you can see, this is the apical collateral. This is a tortuous epicardial collateral going to the right ventricular branch. This is a usual connection between the apical part of the LAD and the right ventricular branch from the right coronary artery. And we have some septal connections to the PDA, but the problem here is that septal connections coming proximal to the anastomosis of the lima. This septal can give or may be connected to the right coronary, and this is sure giving connection to the PDA. But the problem is that both septals going to the PDA coming or arising proximal to the insertion of the limb. So what to do? We decided to go retrograde for this right coronary without ostium. We couldn't identify the ostium of the right coronary, so we tried to go first through septal connections, but we have difficulty to go through these septal connections, and I leave this for discussion. So we decided here to go through this epicardial collateral, and this is a fine cross microcatheter, 150 centimeter, and this is the Sign Black wire. You can, after crossing this first part of the collateral, you can see that the wire knuckled or bended on itself, and this is the beauty of the Asahi wire. You can go safely by these wires by knuckling or by its shoulder through the tortuous collateral, and this is much easier to go through the collateral and more safe. But don't push the wire vigorously. So if the wire going easily, this is the safest way to go through the tortuous epicardial collateral. So after crossing from the distal LAD, apical LAD, to the right ventricular branch, to the right coronary, we try to locate the site of ostium of the right coronary. And this step only took about almost 2 hours. we are trying to find the ostium of the right coronary. We used at this step at least we can say it's 13 or 14 wires from a Stato XS20, which is a wire with a tip load of 20 grams with the highest penetration force. Tip diameter is 0.008, and we couldn't penetrate the ostium of the right coronary with this wire. I tried also Concus Pro 12, 5 wires, we couldn't penetrate, and we tried with the Gaia third multiple wires. So
can we hold a second?
Okay, no problem.
Because we have a lot of junior attendees with us today, we would like to them to have focus and concentration with this wire course. Now this wire course is going through the Lima anastomosis to the LADs and through epicardial collaterals, going back to RV branch, and we are trying to go through at this radio-opaque part to the proximal part of the native RCA. And this guiding caster is looking for the RCA ostium. Where is this guiding caster now?
I tried to inject from this vein graft. Yes, this is a saphenous vein graft with some collaterals, maybe going to the right coronary or maybe going to the atrial branches. So we tried to localize the ostium, but also we failed to localize this ostium. If you are asking about the types of the wire, we used highly penetrative wires, which is an Stato XS20. This is 20 grams, Concus Pro 12, 12 grams, and Gaia third, it's 4.5 grams, but with the special features of the wire, giving it a penetration force up to 9 or 10 grams.
And which microcaster now in the right coronary?
This is a fine cross, and this is here. If you are asking about the safety of using this wire, yes, it's safe because I'm going by this wire through the microcatheter. I'm not going barely with the wire, so it's inside the microcatheter, so it's safe to go and exchange.
This is the point I would like to clarify to all the audience. So this wire is protected by a microcaster, yes. Especially it is in a epicardial branch, which is very risky for perforation and rupture.
Of course. And this is the big problem why we were not able to cross the ostium with the high penetration force, because most of the penetration force lost within the collateral. We have a tortuous collateral. We are going through the tortuous Lima. We are going through the tortuous RV branch and going a bend inside the right coronary and trying to use this wire. So after advancing the wire to the tip of the microcatheter, we are almost losing the control of the wire. So just we are able to push the wire only. But this is the beauty of the Gaia wires. The Gaia wires have a special core, which is a composite core, which enhancing the control of the wire and torqueability of the wire. So this is the only wire I could use under control in this situation. So the Gaia wire is marvelously controlled within this tortuous course. So we tried a lot to find the ostium till injecting from the microcatheter. You can see also we are inside the lumen of the right coronary, but we don't have an ostium to cross. So after 2 hours of multiple trials by different wires, also we tried to go through this saphenous vein graft to find the course of the right coronary or to open the right coronary through this saphenous vein graft. But unfortunately, this is a degenerated saphenous vein graft of 10 years. And it's very risky to go through this saphenous vein graft because you are easily going through the lumen or to the outside of the wall of the vessel. So several trials, we are trying to cross this ostium, and if you can see here, we are not. If you can see that the microcatheter is crossing the site of the ostium, but still in the wall of the aorta. It's not in the lumen of the aorta. So a lot of trials trying to go through this ostium. The microcatheter is going to the wall of the aorta, going any side to the other side. And at the end, after 2 hours of trials, by this wire we could penetrate the ostium or the at some part in the sinus. by this guy third wire. So you can see now the wire is moving freely in the aorta, and after advancing the microcatheter inside the in the lumen of the aorta, exchanged this guy wire for an externalization wire. And this is the wire you can use for snaring. Don't snare short wire. If you are going to snare a long wire, because you are going to take this wire from the other side. Don't try to snare the short wires, because you will be stuck inside the guiding catheter, and you will not be able to use it. So exchanging this Gaia wire for RJ3, which is an 330 centimeters wire, we snared this wire into the guiding catheter coming from the other femoral, and you can see.
Dr. Tarek, before snaring, you change it into RG3, and to do that, you go with the fine cross or the microcaster in the aorta.
Yes.
Is it true?
Yes. First, the wire penetrates the wall of the aorta into the lumen. This is the Gaia third wire. Then advancing the microcatheter into the aorta to exchange this over the externalized wire.
Okay.
So this is the externalization wire, which is RG3 snared. This is a 25 centimeter gooseneck snare, and then we advanced the guiding catheter over this snared wire towards the ostium of the right coronary, and started PTCA by 20 millimeter balloon. And after dilatation, here we have another problem, and we could localize the ostium, but we opened the right coronary towards the right ventricular branch, and we didn't open the distal part of the right coronary, which has another segment of total occlusion. At this step, we advanced a double lumen microcatheter, which is Sasuki double lumen microcatheter. You can see this is the double lumen microcatheter over the externalized wire. And then through this double lumen microcatheter, I used this Fielder FC wire. Also, I pushed it by its shoulder like a knuckle. So open this distal part of the right coronary. And after confirming the position, we started PTCA again to the distal part of the right coronary, and stenting from distal to proximal started by 38 millimeter stent, and then 34 millimeter stent, and 3x18 stent, and we used post dilatation by 3.5 balloon for flaring and for post dilatation of the right coronary. And this is the final result of the right coronary. So the procedural time, almost 5 hours, almost 2 hours trying to find the ostium. Contrast volume is not large because we were trying to open the ostium. This is the problem of the long time, and we used the low radiation exposure. Hemodynamics, patient was stable all through the procedure, with heart rate average 100, blood pressure 120 to 130 over 70, and we don't have any arrhythmic events. So this is, of course, cabbage itself is a frequent cause of CTOs, and treating native disease is much better than treating the grafts, saphenous vein grafts. And you have to keep in consideration that this is more difficult because of you will find a lot of CTOs. Occluded grafts can be used only for retrograde pathway if you can use it, or you can use other grafts to reach the collaterals going to the occluded vessels. But usually don't try to go through the lima from the start, because it's very risky, and you have to keep in consideration that you might have a big or catastrophes while you are using this lima retrogradely to other vessels. So be prepared for any complications. And thank you.
Thank you, Dr. Tariq, very much. Then it is a very, very difficult case, actually. And you did your job in a nice way, and the mission is possible. It was not impossible, Dr. Tariq. Thanks, God.
Now,
we have time for some comments, and of course, we have many from our great panelists for this excellent case. Let me start with a short comment, Dr. Tariq. You said in your conclusion that if you have vein graft, try to use it even if it is occluded. And of course,
totally occluded, yes.
It is patent or occluded. You can try to use it. Especially, yes. It's more safe than using the lima, which is a more important vessel in this patient.
Yes.
Have you tried to go through this occluded vein graft to the right coronary or not?
Of course, I tried, but I was not optimistic for this saphenous vein graft because a degenerated graft for 10 years, it's very difficult to go through it. So just I tried for a quick trial, and I found that the wire is not going to the true cord to the right coronary, so I stopped trying this saphenous vein graft because trying too much is very risky for such patient. As you might have perforation in this saphenous vein graft, and at this time you will find a complication which is not, of course, in your mind.
Dr. Gamal, you hear me?
Yes.
How do you think other imaging modalities could help Dr. Tariq in doing this extraordinary difficult case regarding CT, coronary angiography, or intravascular imaging? Is there any imaging modality of these that might help Dr. Tariq? What do you think, Dr. Gamal?
Before this, I would like to congratulate Dr. Tariq for this great work. And that I have, just to comment, this patient is 31, has this 500 LDL for, 31 years, and CAB is 21. But when you look to the LAD vessel is relatively smooth. It's after the insertion of the lima, the LAD is not so bad. I mean, we have seen LADs with lower LDL like this, with diffusely diseased and occluded and this. But the lumen of the LAD is good caliber. I don't know. And there is one picture. If you go back before the last one, there was like graph going down to the RCA. No. The last picture. Okay, the last one. Okay, the one before, go to the one before, please. Before you start stenting the right coronary. Yeah. No, before that. Yeah.
You can explain your point to Dr. Gamal and tell Dr. Tariq can find the clip that you need. You can explain your point, please.
Yeah, this one. So this is a graph to retrograde of the right coronary or what?
No, it's the lima injection.
Lima LAD and then going lateral to the...
This is lima?
Lima.
I see. Okay, to see the collateral. Okay. I think most slides for the study of the ostium, maybe most slides will be better because intravascular ultrasound. I mean, you have to find where to go with the catheter, but the problem was not going to see the ostium of the right coronary. It's difficult. So I think IVUS will not help you.
Okay, Dr. Jamal, thank you. Go to Dr. Khalid Tammam. Dr. Khalid, you saw the case of Dr. Tariq Rashid.
Yeah, first of all, hi Tariq. I would like to congratulate Tariq for this very tough case. And if it's this my case, I will not do. It's I
Khalid,
feel
my question,
Tariq,
were you going to treat it in a different way?
Yes, because I think Tariq he's very lucky, and he's of course he's very skillful to finish this case with this way, because it's but to do CTO via Lima, we all know CTO operator is afraid from Lima all the time, because the complication to lose a Lima, a single vessel remaining for young patients at 30 years old, you may lose the patients on the table. So the risk to lose the patient on the table, it's very high, not a small, it's very high. And to do, if I'm in my cath labs here, I will put umbrella before starting this case. Anyway, it's he was lucky enough and good enough to finish this case by this nice way. Congratulations, Tariq, again. But there is using a Lima and using a collateral for 5 hours. Patient, of course, he will have ischemic burdens, because you close the collaterals for RCA, of course. And to have another modality, I think, Tariq, to go from saphenous venous graft, it's much less dangerous than going through Lima. Lima is very, very dangerous to go. The risk of dissections. Yeah, I think the Lima, it's the collateral is very nice, and always when we look to the collaterals via Lima, we see it is very nice. But all my colleagues from Japan, some of them they heard us now, they don't touch it. Even we have a very nice collaterals, big collaterals from Lima, we don't even touch it from Lima, because always one mistake can cost us the life of the patient. I know Tariq, he's very good. He can finish this kind of procedure nicely, and lucky enough the patient is okay. But I think if we deliver the message to our young colleague starting CTO program, we cannot recommend to go via Lima retrograde for epicardium channel to native arteries. And this Lima is beautiful Lima for 10 years with very nice LAD and very nice collaterals. So I think we can use another modality, go retrograde from, I don't know, maybe Rima, if the Rima has some collateral, you don't show us the Rima after we finish.
No connections between the left circumflex and the right coronary.
So I don't know, Tariq, but you are nice. I congratulate you.
Your
you
message
finished very well.
Here, Dr. Khalid, patient safety comes first. Patient safety comes first, especially Lima is...
or we send it to Tariq back. Yes. We send the case to Tariq.
Okay, Dr. Yasser Hussein, this guy is 31 years old with LDL more than 500 with bypass at the age of 20. How are you going to treat him medically after this tragic case by Tariq? How to treat him medically now?
First of all, congratulations to Tariq, but allow me, Dr. Walid, if you allow me, we have 3 of the CTO operators with us today. I just met a case 3 days ago in the Journal of Invasive Cardiology about doing PCI to CTO in a patient with saphenous vein graft lesions. And in contrary to the general belief, they stated that the dealing with saphenous vein graft would be more safe than going to fix the CTO. Of course, if, Tariq was right, because the saphenous vein graft was 10 years old and a lot of thrombi and a lot of complications might happen. But what do you think about this article? It's a turning point article. I would like to have a comment from you then to go for the algorithm of treatment, which is not, we will not differ much about the algorithm of treatment as regards the medical.
I think treating the native vessels is the golden rule for post-CABG patients with saphenous vein graft problems, because this is have a better long-term results and better outcome, less myocardial injury during intervention. Of course, if you are going to tackle the saphenous vein graft, you'll put a filter or something like occlusion device.
Class 2A today, I think, not class 1, right?
Yes.
But you would go for a protection device, right?
Yeah. This is mandatory in treating the saphenous vein graft. But I think the golden rule is to treat the native vessels still now. Maybe this article is
it's one article. At the end of the day, it's one article. Of course, it's very a good one in the journal with reputation. But it's one article. You are right. We cannot rely. But I'd like to have your opinion, you and Dr. Khalid and Dr. Mitri.
So we may ask Dr. Mitri what his opinion about the case. If this case in United Kingdom, he will treat it the same.
Well, thank you for asking me to comment. May I congratulate you, Tariq, for a fantastic job. And I appreciate the difficulties. He's a very young patient. You want to do your best for him. The only option was to go down the lever because the vein grafts are now full of crud. You don't know where the wire is going to go. So your only option was the lever. Now, you could have tried to turn the wire upwards and then try and get into the septals that way, but you decided to use the apical collateral. Now, that was very brave because you're a good operator. You've used the apical collateral, but you know it's going into the right ventricular wall branch. So you don't fully own the right coronary artery, even when you went retrograde. And of course, you had when you came up to the cap, that was a bit of bad luck because the cap was very, very hard. And you used a CP12. I think you used an astato, which is like a lance. You tried a Carlino technique by trying to, put some dye on it and create a channel. And finally, the guy at the third, went through. And then, of course, it was a fantastic job of snaring it, externalizing it. And, and once you've got an externalized system, you could treat the front of the artery. And then, of course, you realized very correctly that you don't own the whole artery, and that wire was retrograde via the RV wall branch. And then you managed to get, get the whole artery in the end. So a really commendable job and very, very sophisticated with the way you encountered each problem and then went on to the next one. A very good exponent of hybrid approach of the CTO. I know it took a long time, but you used very little dye, and I'm sure this patient is going to have a very good result.
Thank you so much. Thank you.
Now, regarding the medical treatment, I don't. Dr. Yasser.
Yes.
I think more like PCSK inhibitors or just the high dose of statin and ezetimibe, and that's all, because he has been, I think, on this regimen for before, since the CABG. So what do you think? Would you add this new expensive injectable drug, or you will maintain him on the high dose of statin plus ezetimibe?
I think an LDL with this very high levels, I think this patient is, I don't know, is familiar, but of course he's familiar, but is he homozygous or is he heterozygous? At the end of the day, we will give him the maximum tolerated statin with ezetimibe, and I think this patient will never go to the goal without PCSK9 inhibitor. will never. It's around 600 LDL 600. What a statin would bring him down. I think it will never happen.
Dr. Walid, let me congratulate Dr. Tariq for this fantastic case. It's actually one of the case reports. It carries a lot of messages in the talents for how to do CTO, how to be an expert in the CTO. Another messages which is delivered by Professor Khalid Tamam is how to keep the patient safety. So now, by two experts in CTOs, we have two different pathways from messages, one for talents and how to solve a one-option solution, and another pathway is how to be safe and how to keep the safety of the patient on a track of management of patients. So I think we got the maximum benefit from such a case. And I'd like to thank you, Professor Tariq, for this. I think it is the first time to present this case, and we have the privilege that you presented in CardioGo. I think, Professor Walid, we have to proceed for the sake of time.
And I promise for the Mission Impossible 2.
Thank you
I have one on the left side.
For this excellent case and excellent presentation, take-home messages from you and from all the panelists. Now we come to the final presentation in this very fruitful session. It's our pleasure and honor to have Dr. Ritu Mitra from UK. He is going to give us a very interesting case. And now we come to the third and final presentation of this session, of this very fruitful session. It's our pleasure and honor to have Dr. Ritu Mitra from UK. Is going to present a case of radial intervention with a lot of take-home messages and learning statements to be taken from his experience and how to manage this case safely. Please, Dr. Rita, go ahead.
Thank you very much for having me. Next slide, please. So this was an 80-year-old gentleman who he was suffering from a lot of angina despite a lot of anti-anginals. He has mild kidney disease, and we planned an LAD PCI. Somebody had used his right radial pulse quite a lot, and it was no longer palpable, so we used a left radial approach. We put in a 6-French sheath. And as we were trying to advance the wire, it wouldn't advance. And when we put the fluoroscopy on the wire, we found it in the elbow region. And I think whoever was doing the procedure first, one of my trainees, we think the guide catheter, was pushed in accidentally beyond the wire tip. Next slide, please. So let the video play. So when I saw this picture, I took over as first operator. And the next slide, please. Clearly, there has been a perforation. We pull the guide back, and we can do another picture. And you can see that there's been a perforation in the radial artery, but it's not very clear where exactly this perforation is. Next slide, please. So the question I wanted to ask, number one, should I stop? Should I take the kit out? Should I compress the arm? Shall I call a vascular surgeon? Or should I continue the procedure? Or any other suggestions?
We have to answer?
Well, I don't know, whether anyone has an opinion. Should I stop or should I go? Or should I stop or should I cardio go, shall I say?
Can I tell my opinion?
Yes, of course.
Yeah. Sometimes we stop and we compress the radial and we cross over to the femoral. But I have this kind of perforation, especially when we start the radial approach, maybe 15 years back. So I have the same perforations, and I sent it to my friend in Korea who has trained me. I stopped the procedure at that time. I switch to the femoral. I continue the diagnostic for this patient, and I put a compression, and that's finished. But he sent me a picture back. Surprisingly, he continued, and he put a BCI wire and he passed the radial through this kind of perforations, and he passed to the brachial, and then he put a long sheath 7 French, and he was able to compress this radial. So at that time, I was just laughing how he deal with this kind of perforation. So it can be, if you have this kind of luck, that a PCI wire can pass to pass this kind of perforation and not going to outside the vessel, and then you got a long sheath with a big size like 7 French, and then you continue the procedure, and then you seal these perforations.
Okay, we'll move on to the next slide. But thank you for your comment, and that is exactly what I did. I managed to wire the vessel, and let that play, please. And you can see there's a workhorse wire which goes up and all the way up the arm.
I'm sorry to tell that. I'm so sorry.
No, not at all. No. I think it was a good, it was a good discussion, because I was in two minds whether I didn't, and there is no right or wrong answer, and I decided that I would carry on. So anyway, I passed the wire up, and I said, okay, we're going to continue. Next slide, please. Next slide, please. Could we have the next slide, please? Thank you. And let that play. So as you can see, I've managed to get the guide down. The only way I could get it down was to balloon track it. I put in a 2.5 millimeter balloon, made it protrude to the end of the guide, and made it ride the wire so that it didn't damage the artery any further. I got it onto the coronary, removed the balloon. The guide wouldn't sit properly, and you can see that the tip of the guide is no longer as happy as it was. There's a slight bend there, but I decided to accept it and try and fix the LAD. The wire is in a circumflex branch just to stabilize the guide, because it doesn't sit properly. But at this moment, I didn't want to change the guide or anything because of the perforation. And you can see there's a tight lesion in the mid LAD. And the next slide, please. Next slide, please. Thank you, and let it play. So as you can see, we've now fixed the LAD, we've IVISed it, everything is looking good. And now we are left with the fact that this gentleman has a perforation in the radial artery in the arm, which we have kind of temporarily tamponaded with a guide catheter. Next slide, please. So here we are. Let that picture play, and I've dragged the guide down to see where this perforation is, if it still exists, and there you see it.
The recurrent.
Yes, it is. So the recurrent branch of the radial has a perforation in it. So the question is now, what would you do?
If I may say something, I think, I think the balloon tracking, balloon-assisted tracking is very important for many reasons. One of them is trying to block the site of the perforation while behaving with the complication. The other thing, not to give another harm to the vessel by the guides. And this allowed you to continue your job at the coronary level. So I don't know what exactly you choose, but I think balloon assisted tracking might be a good option.
Yeah, that's what we did to get the catheter up, with a balloon track. So next slide, please. So what I did was, I just decided to inflate a balloon there and leave it up. And I left it up for a good 10, 15 minutes.
Yes, this is a third type of tamponade to seal the perforation. The first one, as you said, as you did, is guiding catheter tamponade. The second one is sheath, long sheath to tamponade the perforation. And the third one is balloon inflation at the site of perforation. So 3 types of tamponade in order to seal the occlusion, the perforation. Yeah.
So we've inflated this balloon because the perforation is actually not in the main radial artery itself, it's in the recurrent branch. So we've inflated the radial artery, we've left it up there. But next slide, please. And it hasn't sealed. So I decided I'm going to put in a covered stent and occlude the recurrent radial artery because the perforation is coming from the proximal part of the recurrent radial. Next slide, please. But the fact is, it is still leaking. And this is a 2.5 millimeter covered stent. So I decided that, and it's still leaking. So, as in my experience, sometimes the covered stents don't really expand, properly. And you have to sometimes post-dilate it very, very gently to make sure it opposes. So I decided to go with a bigger balloon. Next slide, please.
Excuse me, Professor Rito, what is the size of the covered stent did you use there?
It was a 2.5 millimeter covered stent.
Oh, yeah.
Next one, please. It required a lot of post-dilatation because the stent hadn't fully expanded. And the next slide, please. As you can see, the perforation is sealed. The arm, I had compressed it from the externally as well. Next slide, please. And the gentleman went home after 8 hours of observation. We iced the arm, we compressed it, we elevated it, and the patient's doing well. Next slide, please. So this one happened only about 4 weeks ago. Again, as the operator was advancing the wire, they found resistance. And when they took a picture, there was an extensive perforation. What would people do here? Should I stop or go?
We can stop, Dr. Rito, and have some discussion. Yes. The first case was in a left radial perforation, not right radial.
That's right.
Yes. Do you think because of the positioning of the left arm with some degree of flexion may accelerate or increase the incidence of perforation rather than the right radial, which is a straight arm during the intervention?
It could be because sometimes the angle, the way, the arm angle, the way it is bent can cause, problems. So you have to be quite experienced to recognize it immediately and deal with it. I think there's a slightly more increased risk in the left radial. However, it's not been proven that this is the case, but you do have some case reports where this is more common in the left radial.
Observation, huh? It's observation. Yeah.
Yes. Anyway, for the second case, I actually didn't do anything because I felt that putting in a covered stent here would not solve the problem because the perforation was so diffuse, nothing would happen. So what I did was I balloon tamponaded it, upstream, and hoping that the guiding catheter would tamponade it downstream from the palmar arch, and I left it up there for 15, 20 minutes. At the same time, I put a blood pressure cuff on externally on the arm. And the next slide, please. And the lady was absolutely fine, and she stayed in overnight. And actually, she's coming back tomorrow on my waiting list to have a second go at this problem.
And in such cases, reverse heparin, Dr. Rito?
I think you have to play it by ear. I think if you have a localized perforation, it's fine to try and use methods such as covered stenting. But if it's a much more diffuse damage to the vessel, then I think it makes sense to call a vascular surgeon to try and compress this, to try and tamponade it as much as you can. And then if it doesn't work, well, the vascular surgeon will have to go in and try and prevent a compartment syndrome from happening. Luckily, no heparin had been given in the second case, so everything settled down quite nicely.
Yeah, I think the second case is a very old lady, yes? The bones is very old.
Yeah, they are both old.
Yeah, I think it's, Walid, this is it's quite often happen when you deal with old lady with a very small radial and let your fellow start to the procedure. Yeah. And then they call you up that he has a resistance, but he's already pushed the wire very strongly and he's already perforate, and the operator came and to solve this kind of problem.
Yeah, absolutely true, Khalid. Risk factors for perforation radial artery, as you said, is old age, female gender, tortuosity, short stature, and spasm. I think most of these factors are present in system.
Yeah, but it's very nice to show this kind of perforation, because if you would like to do 100% radial, you have to be familiar with this kind of manipulation for radial, because otherwise, sometimes almost of them they are going smoothly and without any complications. But sometimes compartmental syndrome and hand ischemia may occur especially in old lady. And sometimes it's catastrophe, so losing the hand is very, very messy.
Yes. Can you have comment from the panelist, please, Dr. Gamal?
Yes, I think that the first case, the extravasation was considerable, and leaving the case just by compression wouldn't help. And the decision to continue and trying to establish and putting the guide is good, because even the guide will maybe straighten the vessel and decreasing the ooze, and sometimes decreasing the defect, or after that when you try to work. But the challenge is to manipulate the 014 wire in this big extravasation without knowing before. There is no picture for the vessel. Maybe there was a kink or stenosis or something, but you are just trying to manipulate to upper part. So I think the decision is you should continue. But if not, or if you couldn't establish the guiding catheter, I think surgery or calling the surgeon, because just compressing this severe extravasation might be risky for this 80 years CKD patient. So this is the first. The second, I think, what happened in this case that the wire went into the initially went into the current branch with something. So, and it was stuck here. So the guiding followed this. When they withdraw the wire, the guiding injured the origin of the current branch. Make all this. I think so. But it's very informative.
Thank you, Dr. Gamal. Very valuable comments. Dr. Rito, in the first case, just two short questions. First one, you discovered the perforation before or after giving the bolus of heparin for BCI?
I discovered the perforation before giving any heparin.
And you didn't think not to give heparin and postpone BCI for another session? You injected heparin after that? So
I reasoned it like this, okay? Because I agree with my professor colleague who said that this perforation wouldn't have just stopped with just compression. I would have to call the vascular surgeon. Now, this particular man was suffering a lot of angina, and he had waited a long time trying to, get this procedure done. And he would have to have hand surgery with a vascular surgeon to solve this problem. And you'd have to have a general anesthesia, with unstable, with very, very bad symptoms. So I thought that if I could wire this artery, and if I could tamponade it and solve the coronary problem, and we could deal with the hand, later on. And if I can tell you that if I didn't wire it, I would have stopped there, and I would have compressed the hand, and I've called the surgeon and said, well, we just have to go with this. But luckily, because I managed to wire it, I managed to get the case done, and then we ended up with the hole having been sealed.
We have a lot of radialists in the panel and the presenters. Have ever anyone of us called the vascular surgeon because of radial complication?
Yeah, I did 2 times.
And what was the intervention done, Dr. Khalid, by the surgeon?
Before this always, when you start the program. So, this was 15 years back, not now. So we call because sometimes we cut some part of the sheath inside the radial arteries. They have to take it. And some of this kind of perforations, and to be honest, these 2 times, one of them we was able to get out the part of the sheath outside without surgery, and the other one, the surgeon just say, we will observe the patients. We will not go, and we did with a balloon. But sometimes you have to have opinion for surgeon, because sometimes a surgeon
for legal aspects, for example.
Yes.
Putting a balloon expandable stent, Dr. Yasser. Dr. Ito put a balloon expandable covered stent, and we all know that it is liable to compression. It is not a self-expandable nitinol stent. And the area of the forearm is liable to muscular affection that may compress this stent. What's your comment, Dr. Yasser?
I think it's written in the literature to put it, and no complications would happen. But I think for the junior colleagues with us, we have a very important message, because this ordinary PCI went into a complication. Just as Dr. Mitra said, one of the trainee advanced the cath beyond the wire. So be aware that you never do this. Second KG lesson is never to push against resistance. And one of the important things to do is not to give bolus or to inject vigorously, because you might have a dissection there and the flap might be widened, and the compression of the flap may occlude the artery that is not occluded. What I'm going, if you allow me to ask Professor Mitra about when you use balloon assisted tracking, do you use low pressure 3 ATM or 6, or you go for low pressure, and if it's not helping you much, you go for moderate pressure modality?
Well, I use very low pressure. 4 atmospheres, 5 atmospheres maximum, and then the lowest pressure which works is the best pressure. There is no point trying to put in very high pressure, because that will create more problems, more damage. So the lowest pressure you can get away with, the better.
My final comment is, it's safe to overdilate a covered stent from 2.5 to 4. We're usually afraid to go high because you induce tearing of this cover or this mesh. Is it safe, Dr. Mitra, to do that?
Well, let's put it this way. The patient's blood pressure was quite good, but my blood pressure was a little bit on the higher side, when I was trying to use the size 4 balloon. But I realized I actually had a vascular surgeon come into the room and standing by. And I said, we either try this or you have to open the arm. And he
gave you the courage,
you have to just try this. And so, I tried. And we know that some of the covered stents, they don't open up properly, and you have to sometimes give it some help.
It won't be worse. It won't be worse than this.
Yes.
But it worked. I think because of the sake of the time, we came up to the end of this amazing session. We enjoyed 3 cases by 3 elegant presenters. It was honor and pleasure to have you, Dr. Ritu Mitra from UK. We enjoyed your presentation very much. Your take-home messages were clear and very beneficial. I would like to thank Dr. Ahmed Bindari and Dr. Tariq Rashid for their cases. It was a great pleasure to have my dear friends and professors as panelists today, Professor Gamal Abu Nasr, Professor Khalid Tamam, and Professor Yasser Huzayin. Valuable comments and discussion.
And thanks for the moderator, the great moderator today. Thank you.
Of course. The founder of CardioGo that gave us this chance to meet each other and to have this great benefit today. Thank you, Dr. Said, and thanks to ICOM.
Professor Walid. And
thank you,
I'd like to thank you all for this great session. I think also the cases presented carried a lot of educational messages. By the way, it is moderated, and by the way, it is interacted. I'd like to thank you all, Professor Mitra, Professor Gamal Abu Nasr. I'm happy to see you today, Professor Gamal, Professor Yasser, my dear friend and my dear brother, and finally, my dear brother, my dear colleague, Professor Khalid Tamam. And I hope to see you in Egypt soon. Dr. Bindari also presented a great case, and I'd like for all of you to smile to take the final picture of the ICS2. Please smile. Thank you very much, and we will come to the end of the session, to the end of the day, and we are waiting for you all tomorrow for another ICS 3 and 4 with very fantastic and interesting sessions waiting for you there. Thank you very much.